Whoop, sorry about that. Good morning. Okay.
Hey, good morning.
Good morning.
Good
How you
evening.
doing?
Yeah, I'm fine.
Very good.
Yeah, I'm preparing for the meeting. So, just like yesterday, I tried to translate.
Did it go okay yesterday?
Yesterday, yeah, it gone okay.
Good. Good.
Okay.
Okay.
This time also.
Okay. So we'll talk later about the setup. Okay. Because I want to see. I want to learn. Okay.
Okay.
Okay. So
Okay.
I'll talk to you later.
Okay. Thank you.
They are live now, so I'm going to screen share, okay?
It began just before.
Yeah, they're beginning now. A few minutes. Oh, I gotta make, oh, I didn't do that. Okay, I gotta make sure I share the sound. Okay. What the heck? Oh, okay.
I don't want to celebrate this much.
You should.
Okay.
Unless you can subtract rather than to add on.
And Professor Kato is here now.
Yoko is with us.
Can't see Madam very clearly, just the upper half. Hello.
Now she's there. Hello, Yoko.
Hello.
You, I think, can't hear you.
Unmute yourself, Yoko. Do you see her on the screen? I don't see her on.
Yeah, she's
Keep,
on the screen and is now
sharing the screen now.
unmuted and is now sharing her screen. But I can't hear her.
When we put this program, we considered the regional time zone. So we don't want Joha to be after midnight, staying with us for the late night show. Yeah. So
Thank you very much. Thank you.
Yeah. That's why we took Yoko and Joha earlier than the others.
Thank you very much.
Thank you.
But Juha, you should wait for More. You have your usual battle.
Yeah, we are
my
waiting
friend
for-
is coming. I will wait for him. Yeah.
Good.
Okay. Yoko, are you hearing us?
She's muted. Yoko, you're muted, I think, still. I can.
But
unmute
Juha, you
you,
should
so
wait
I
for
will-
More. You have your usual battle.
There we go.
Yeah,
My friend is coming.
Yoko, good to see you.
Hi, how are you?
How are you?
Fine.
Nice to see you again.
Thanks for joining us.
Thank you
Are you
for
hearing
inviting
us?
Me.
It's
Thank you
a
very much.
pleasure.
She's muted.
So Yuhan and I is from Asia. So the China is now is 8 o'clock, 8 p.m. now.
8 p.m. And in Japan,
China.
it's 7
Japan is
9 p.m.
9.
9 p.m.
Okay.
Yes.
Mexico 6 p.m. Hello, Yoko.
Six.
This is Victor.
Hi. How are you?
Yoko.
Hi, how are you? Vladimir. Wasn't
So we are waiting for Jack Murray to join us, hopefully, on time. We have 2 more minutes. Yoko, what is the background of your picture behind you?
some maybe some Christmas time from Europe,
Oh, okay.
somewhere in Europe, I think.
Oh, okay.
Not China, not
Not
Japan.
from not Japan. Okay.
Yes. あ、多分大丈夫でした。さっきの。
Good to see you, Yoko. Moody.
Yes.
How
Who
are you?
is talking? Who is
Moody.
talking?
Moody Qureshi.
Hi, Moody. Good to see you.
Takeshi.
Hi.
Hi, how are you? Still, I don't get your reply.
Start, perhaps Jack will join join us later on, and the same with Dr. Mustafa Baskaya and others. It is my pleasure first to say hello to all the colleagues, the members of the committee, the invited guests, international and regional colleagues, and trainees and attendees around the world, 6 continents. It's a special, really, inauguration of our webinar for this specific 7th webinar that has accommodated constellation of stars in their field. And I want to dedicate this webinar. Usually we don't do this one, but I thought for this specific topics, I'd like to dedicate it to the master, Professor Ghazi Yazagi, who has taught all of us how to aneurysm and many subarachnoid hemorrhage. At the same time, I'd like to dedicate it to my close friends who we lost him years ago. Professor Pierre Lajvanias was the greatest intervention radiologist, and we should. Okay, I think we're going to start. Perhaps Jack will join us later on, and the same with Dr. Mustafa Baskaya and others. It is my pleasure first to say hello to all the colleagues, the members of the committee, the invited guests, international and regional colleagues, and trainees and attendees around the world in the 6 continents. It's a special, really, inauguration of our webinar for this specific 7th webinar that has accommodated constellation of stars in their field. And I want to dedicate this webinar. Usually we don't do this one, but I thought for this specific topics, I'd like to dedicate it to the master, Professor Ghazi Yazagi, who has taught all
ガズヤサジールが始めたのですけれども、
aneurysm and many subarachnoid hemorrhage. At the same time, I'd like to dedicate it to my close friends who we lost him years ago. Professor Pierre Lajvanias was the greatest intervention radiologist, and we should keep him in our heart and mind.
このような熱意をいつまでも維持していたいと思います。
I'm going to chair these sessions. I'd like to thank the team. I'd like to thank Professor Benish for his continuous support as chair of the Neuroanatomy Committee, and the members, all of them, they are with us today because really it's an exciting program that will cover the aneurysm management in all aspects. We have today, I'm going to introduce shortly Professor Yoko Kato. She is the lady. She doesn't like to use that word. She is the neurosurgeon who was known for all of us without any introduction. Everybody around the world, especially these juniors, when they say Yoko Kato, they know she is the educator worldwide, and her contribution to the education of young neurosurgeons is unlimited. And she is always on the flight now with the COVID. I don't know how she managed, but she shifted to the Zoom like all of us. And she is an expert in her field in the vascular neurosurgery. And in specific, I attended several of her lectures on the endoscopic application and aneurysm surgery and the, of course, the fluorescein guided clipping of aneurysm. She's going to give a presentation on the update and modern approach to management of aneurysm. Kato, the venue is yours.
Thank you very much, Imet, my teacher. And thank you very much for the WFNS Neuroanatomy Committee invited me tonight. Japan is 9 p.m. So I would say that tonight. And also I want to say thank you very much to Vladimir Benesh. That he's been more than, I think, 20 years, my teacher and also the friends. I'm so happy to see there are many my friends face today. So the Imat is special, my teacher and friend, because he is one of the advisory board of the Asian Congress, and his dedication to the ACNS is huge. So thank you for your dedication to the Asian education.
Pleasure.
So tonight I would like to talk about a little bit the aneurysm. I want to share. So this is, I want to start, this is a paraclinoid aneurysm. So this is partially thrombosed. So the thrombus is a cap on the paraclinoid part of the aneurysm. So as always, we exclude of the anteroclinal plexus. And I'm always very peculiar things about, because main vessel, which seems very healthy, but suddenly there's some special aneurysm, the wall is very thick and yellow. So here you can see that is the aneurysm. So we switch of the treatment during the surgery because at the beginning we thought the aneurysm location is close to the IC top, but we understood the aneurysm location is very close to the paraclinium. So we switch to the high flow bypass, and this is neck, and now we expose of the carotid and the EC and IC, and we make a channel, and this is M2. So we took the radial artery about almost 17, 18 centimeter, and then we through the channel. We introduce of the radial artery to the M2. Then the usual, the suture, radial artery, and the M2. So this is neck area. So this is a suturing, continuous suturing of the neck side. Then I want to, of course, the Doppler and so the ICG. So once we open the channel, so very nice flow. Now we can check the behind the aneurysm. This is IC2, and here is the aneurysm. Aneurysm is the surface is very yellow. This, but some part is still not the complete cap by the thrombus. So that's why we try to do the treatment for this patient. So this is one case. So next one is ICPC. This is very just usual, but the patient has lots of bleb on the aneurysm surface. So again, most of the IC, EC or IC proximal side of the base, usually we remove all the anteroclinal process because of some movement of the IC. That's make the help to the easy to see the aneurysm. Now here's a very thin part of the aneurysm. The other part is bleb, so-called bleb. But now you can see very white or yellow. And this bleb, so-called bleb, everybody think the bleb part is very thin. But now you could understand. So this is remodeling of the flow. So maybe this is a late part of the aneurysm formation. So from the red to yellow, for most of the case. So that we cannot judge the aneurysm, some future, the rupture or not. So we cannot judge only by the size, only by the shape of the aneurysm. So we should know that. And also another advancement is microscope. This is everybody now use of the kinebo. So position memory is a very good function because kinebo 900 is almost a robot. So just we can adjust the many parameter. So then we can exact the size, same location. Then it's quite easy to compare with the before and after clipping the flow 800. So this is a point block system. So we can use both hands. So this is the big advantage. So we can use non-stop. We can work for the. From here is just I want to tell you about the partially thrombosed giant. So just I want to tell because this is not intraluminal disease. This is intramural disease. So there are two types of the aneurysm. I talked for many times. So this partially thrombosed aneurysm is almost just like a meningioma, the mass effect, or thromboembolic event. So this is the main role is by the vasovasorum, proliferative disease of the vessel wall. So vasovasorum, or sometimes the 5-LO, is the main cause of the enlargement of the aneurysm. So many choice of the how you can treat of the large or giant aneurysms. So the observation or medication is of course not good. But sometimes the endovascular treatment such as coiling or with stent, that is no effective. So because of the cause of the aneurysm growing is not main trunk, but also the aneurysm wall itself. So sometimes flow diverter is sometimes effective. So this is, I showed you many times. So this is posterior fossa, the giant aneurysm. So this is after skull base, the bone drilling. Just I want to show how we can see the aneurysm wall. So through so many cranial nerves, so we can see the very big vasovasorum. So this is so-called main cause of the enlargement of the aneurysm. So I want to show the aneurysm wall, the partially thrombosed. This is totally different from the usual, the large type of the aneurysm. So this is a check by the histopathology. We can see the vasovasorum in the aneurysm, the wall, and this is another case is both sides of the large or giant of the cavernous location of the aneurysm. So this is also I want to show some histopathology. Again, this is a high flow bypass because at that time we cannot perform the flow diverter. So this is a saphenous M2 bypass. So this is a revolution, kind of a revolution. This is image. This is a dual image angiography. This is a saphenous high flow, and this is a so this is a procedure. The patient has some pathological part of the IC, so we send it to the pathologist. And finally, the patient, the disease is Ehlers-Danlos syndrome. So second stage, the left side, we did the coiling. And now is the era of the endovascular. So of course, flow diverter, it has lots of complications still. But the giant can be treated by the flow diverter now. So even the blister-like aneurysm is one of the indication. And also the MCA is treated by the endovascular now. And also this is one of the devices, the web. And also the super stent is coming up now. So this is a P-conus. And also the pulse rider is the recent one. So anyway, this is flow diverter, so many types. And this is very interesting case. This is, but even after coiling, still some recognition. So you can see the green part is treated by coil. So, but the recognition was occurred. So we did the surgery. So this is the left side. So already you can see this part is here. You can see the coil. So this is second nerve, and this is a coil. And this around this part is recognition. So patient come to us. So this is endoscopic view. So this is a second nerve, this is IC, and here is the recognition aneurysm, here. So for this case, we put the 2 clips for complete elimination of the flow from the circulation. So this is the first one, and 2 clips. So even the coil part, we close by the clip. So that is, we did not exclude the coil for this case. This is reinforcement by glue. And this is a post-op. So after putting the clip, so almost complete elimination of the flow from the circulation. So the most techniques we should know, the so-called hybrid neurosurgeon, especially the younger generation, the neurosurgeon. In Japan also, we have a 10,000 endovascular neurosurgeon, and those endovascular neurosurgeon also can clip. So they can choose how they want to treat the patient. And also the CFD. So this is very interesting. Of course, this is some definition, wall shear stress or vector, or so those combination, the synchronized combination, we can judge which part is very thin or thick of the aneurysm. So just we can superimpose of the 3D CT. So this is the 4 parameters, so vectors, pressure, and wall shear stress. So this is how we can use or how we can utilize of the CFD for the clipping surgery. So this is the large type of the aneurysm. So some part is very thin. So just we estimate by the CFD. So this is a not so big one, but this part we send it to the pathologist. So the degeneration or inflammation change, we check the image and also pathology. So these findings, I think sometimes the aneurysm wall was completely stabilized due to remodeling. So that means it's no need for treatment. So we can understand before we go to the surgery. So this is the giant, the budger trunk aneurysm. So this is the angio. So the DSA showing the recirculation flow with area of the stagnation. So those part is stagnation part can be the very thick of the aneurysm wall. So that is a CFD. We can estimate which part is thin, and this part is thick. So the multiple area, the high oscillation, the wall shear stress representing change in flow divergence. So this is a parasigmoid approach. Here we can see the fifth nerve. And this is the aneurysm wall. So this is, so this time, unfortunately, we do not have a long size of the aneurysm clip. So a little bit shortage of the length. We cannot reach the aneurysm.
There we go.
Aneurysm and the yellow part is a major trunk. So we can see the flow in the aneurysm sac and stagnation. So we put the 3 clips for this case.
There we go.
So this is endoscopic view. So we add 1 more clip, but still it cannot be complete occlusion by the surgery. So only this part is we try to the two times the coil because patient is over 80 years old. So this green part, the first coil, and only the green part is the obliterated. And the second time, so this is the first coiling, and this is the second time coiling, so complete the aneurysm is occlusion. So this is a model of the growth of the aneurysm. So this is a high wall pressure, this part. This is the initial, the aneurysm formation. And the second step is so change of the impact point. So this is a recirculation flow. So this becomes the very hard. And the start of the enlargement and the thinning of the wall. So this is a very complicated the schema, and this is the mural degeneration, and also this is I'm sorry. So this is apoptosis relation, and this is a morphological inflammation, and this is a thrombus progression in intraluminary. So these three can be the aneurysm growth. And also the predictor of the aneurysm. So maybe I talked many times. This is an enhanced wall of the aneurysm by MRI. So this is an enhanced part of the aneurysm. So this is enlargement. This is a grade A, B, C, D. So this is a paper from the Tohoku University. The Japanese found this phenomenon. And this is to discriminate between the stable and unstable aneurysm, especially the larger one, and also relation with the ACA, ACOM, and the ICPC. So this is Aoki and Nozaki. Also, again, the Japanese researcher pointed out the relation of the enlargement aneurysm is inflammation, such as a macrophage relation, and also the recently the good microbiota is relation. So the preemptive medicine is effect for the every stage. And also the Nozaki wrote a paper about the relation with the statin. So this is one of the cessation of the aneurysm growing. So this is very busy slide, sorry. So this is Omodaka is from Japanese Tohoku University that he mentioned about the enhanced the aneurysm wall by MRI. This is non-invasive. So this corresponds to the basal formation and inflammation. So the CFD and the wall enhancement is the current non-invasive some prediction of the aneurysm thickness of the wall and some kind of the predictor of the aneurysm, which is going to premature. Sorry, so the rupture in the near future. So the preemptive the medicine can be established with the specified biomarkers and imaging modality to prevent or delay the onset of the symptoms of cerebral aneurysms. So the future trends is, of course, one is endovascular devices, the development. On the other hand, so still we need some microsurgery for such as a very large or ugly the aneurysm. So we need some technique of the bypass surgery, and also the image advancement is also very helpful for the aneurysm, the surgery. Thank you for your attention. Thank you very much.
Thank you, Yoko, for this wonderful overview of the contemporary practice of aneurysm, covering different aspects, including the growth and potential medical help, and complemented with fluorescein-guided clipping, and among other activities. I open the venue. Let me see, there are 2 questions in chat. There is no question on the chat, and I'll open the venue for the panels if they can. We can take 1 or 2 comments or question to Dr. Kato.
Can I start?
Yeah, go ahead.
A question for both Kato. Madam, is Ramesh here?
Yeah.
My question is, if you have like a paraclinal aneurysm or a low-lying IT aneurysm, would you offer the first choice for treatment to an endovascular specialist, and then if they refuse, you take it for surgery? Is that your policy?
Yes. If the patient is young, so I want to offer the open surgery, because the age is young, so they need some the long time of the anticoagulant. So and also if the shape is nice for the endovascular, of course I can offer the endovascular treatment. So up to some condition. So the paraclinoid and such as posterior circulation can be treated by the endovascular. That's concept is still I cannot 100% hold. So the condition is very important.
Thanks.
Any other questions from the panelists or comment?
May I?
Of course.
Compliments, Yoko, wonderful presentation. I think that you has to be emphasized that at this point, for let's say normal aneurysm, the discussion in between interventional radiologist and surgeon has to be on the daily basis. On the other side, for the giant, I think surgery remain with bypass and open surgery the only things to propose to the patient. Thank you again for this, mainly for the radiological improvement of the planning, preoperative planning, preoperative or coiling planning. I think that our friend interventional radiology has to learn a little bit of radiology from you. Thank you again.
Thank you. Well, I think I will thank you very much, Yoko, for your contribution. I may invite our next speakers. It's an honor to have him. I think he is the cloned Yazavjil in our contemporary practice. He is the highest experience aneurysm surgery, active and living. He is the chair and professor of the People Hospital in Henan, Zhengzhou, His department exceeds the 600 beds, and he has 150 neurosurgeons under his supervision. It's a pleasure that we have him to share his vast experience talking about the state of management of aneurysm. Juha?
Dear Imad, dear Vlad, thank you very much for inviting me here. So I will speak about the state of aneurysm surgery now in the world. Can I have my slide? No. Yeah.
Professor Kato, could you? Oh, that's fine. Yeah, thank you.
Can you see it now?
Yes.
Yes.
Okay. Okay. This is my topics. This is a sentence we wrote with my teacher, Skip Peerless, nearly 30 years ago. We continue to enjoy the perfect clip around the base of those deadly sacs. So this has been my life. And now working in China, perfect clip around the base of those deadly sacs. Is it over now? Like in the song, those were the days. This is unruptured right middle cerebral artery aneurysm. I still think that these aneurysms should be operated on by clipping because they are superficial and simple for clipping, very complicated for endovascular surgery. This is the operation. Simple lateral supraorbital flap, one layer. And this is very fast. So in 10 minutes, I'm opening the dura, one burhole, 2 cuts. Then we have the flap here. I'm opening the dura, and then under high magnification, opening the Sylvian fissure with needle as knife and injecting water inside the Sylvian fissure to distend it, and then opening the Sylvian fissure distally, saving the veins, going to the aneurysm. Soon we will see the aneurysm wall. It was growing in the observation. Now we see that this white wall, this looks very thick, but there was a bleb that was growing, and that's why the patient was sent to surgery. Careful dissecting under high magnification, the aneurysm. And below the aneurysm is M1 coming from distal. So we dissect after clearing the aneurysm fundus. We clear the M1, go there. This is the bleb. There would put the aneurysm rupture in the thinnest part. And now we go to M1. See the perforators there. You should not put temporary clip around them, save them. For a short time, you put temporary clip here, going here, golden color clip, and then a J-formed clip is taking the broad base. And checking the situation, taking the temporary clip out carefully, and then checking the situation. We need another clip and 2 small additional clips to take the whole aneurysm. Coagulating, but this is here the wall is thick, so it is not so good for coagulation. And then putting a similar clip there, one more to take where the aneurysm is filling through the handle of the clip, and then here one more small clip. And then checking the patency of the M2s with Doppler, and then doing ICG also, and this is Doppler probe. And this is the post-operative CT angio. The patient flew home to Italy 4th day after operation. This was a sister of Guido Guglielmi, Maria Guglielmi. Why I'm showing that? Because it is important that the doctors select the best treatment for the patients, and you should recommend the most appropriate treatment for the patients. Patients are not doctors. Patients should not select the appropriate treatment. They should ask for the recommendations. So now I come to the point. How are we doing? This was the morning question of my teacher, Professor Skip Peerless in Miami, nearly 30 years ago, always. How are we doing? I could never answer that time. Terrible. Should I now answer? Terrible. How are we doing? Why microsurgery is going down? Why are we losing our skills? It is deep cap, fears, lack of skills, poor training, love of comfort, means less experience, fears coming, big threshold to operate on. So why microneurosurgery is going down? During my time in Helsinki, 95% of the aneurysms had open microsurgery. Now only 1/3 are clipped. So the times change. And in my present hospital, Henan Provincial People's Hospital, Zhengzhou, this is like a paradise for aneurysms, but more than 1,000 of them have endovascular treatment and 300 to 400 have clipping. So neurosurgery is not different from any sports, arts. Hard training is needed. So in good microsurgery, only training makes a master. You have eliminated the tremor, analyze your experience, and microsurgery, the training is extremely long. So it is the regular rule is 10,000 hours training. You are at the world top. And this is my addition. If you have been 10,000 days in operation room, then you are at your best. So here is one more video I want to show. Now running. Yes, okay. So this is a giant basilar bifurcation aneurysm, 68 years old. Female, large ball-like aneurysm, right subtemporal broad, going to the tentorial edge. You see here the trochlear nerve, and then cutting the tentorium, fixing the tentorium to the middle fossa floor with clips, and then we go to the basilar artery. Put temporary clip there, and also on both peak arms to have as slack aneurysm as possible, and then opening the aneurysm, because you cannot clip this aneurysm without opening it, so it is bleeding. There's also a small venous bleeding, and then first clip is ring clip going around the base, large base, and then many adjustments of the clips, because the first clip is closing the PCA. So I'm traveling with the clips backwards from the base of the aneurysm. The strong base, of course, in that kind of large aneurysm. So you have to leave some base not to occlude the bifurcation. And till bleeding, so means that the clip is not long enough. So finally, 2 strong straight clips took the whole aneurysm and bleeding stops. The ring clip is taken away and replaced by 2 strong straight clips. Now the temporary clips taken out, then ICG, checking with Doppler still, patency of, these are the postoperative images, and this is postoperative angio, 2 strong clips taking the giant basilar bifurcation aneurysm. The question is, of course, can I do it again? Can I repeat it safely? I have operated around 600 posterior circulation aneurysms. Can someone learn it? Someone younger, can it learn it to do well? Basilar bifurcation clipping needs long training. Could I do it again? Can someone repeat it safely? Can someone learn it? This is the question nowadays. So, huge pressure from surroundings nowadays. Media, colleagues, lawyers are speaking about endovascular surgery. This one, you can push the coils after training in 1 year. In endovascular surgery, you cannot clip basilar bifurcation aneurysm with 1 year training. You need 10, 15 years training. This is the big difference, and of course, handicap for microsurgery. There's also a lot of money going around in this treatment. Many or most of us are seduced by the money. Money. Endovascular is one of the biggest business and heavy to compete. Quite frankly, if open microsurgery wants to survive, we have to be good and efficient, both. Only perfect follow-up tells the truth. This is extremely important and very seldom. So perfect follow-up is a must only in Finland and some other small countries. You have a good follow-up. I have been around the world and have seen the follow-up in so many countries. Worst or no follow-up in largest countries with the biggest economies, and also by those traveling around the world who are treating aneurysm, there's no follow-up. So time will tell. They will open their eyes, is my guess. I hear this many times in congresses, in my series. In metropoles, the follow-up is maybe 5 minutes, or we are waiting for the figures. We are waiting a long time, but you never get them. So without follow-up, you don't know what happens with 10, 15, 20 years follow-up. You will see recurrences, both in endovascular surgery, but also in open microsurgery, like you see right down. You see that the basilar superior cerebral artery aneurysm recurred 15 years later after surgery. So this is the series from Helsinki and Kuopio, extremely good follow-up. More than 22,000 aneurysms in 18,000 aneurysm patients followed up many years until their death in the databases. How to do better here in the treatment of aneurysms? It is never too late to train hard. Training, learning curve is all of your life. You should train your best young people. They should become better than you. This is very important. You should support them to become better than you. So nowadays there's extremely heavy pressure of the surroundings and society in favor of endovascular surgery. Those who are doing open microsurgery, they have to be mentally extremely strong. There are many different cultures around the world. One of the important things in China is that here is the habit to shave the female hair for craniotomy. This is, of course, in favor of endovascular surgery. This shaving of the female hair is one of the oldest and worst punishing violation of females. Also here in China, like in many other countries, there are superstitious thoughts that open the head is dangerous. And if you do very extensive approaches, they certainly look terrible and are complicated. You should do opening of the head. Simple, this is simple microsurgery. Lateral supraorbital flap from skin to skin, middle cerebral artery aneurysm ligated in 25 minutes from skin to skin. So, and the flap should be large enough for your skills, for your instruments, for the lesions, because surgery is not sports. Patient is paying for that. Who have clipping nowadays in the world? Poor people in China, poor people, patients without insurance, and who have no treatment, like in Nepal. Poor people didn't have any money for even for a clip, so they went home. Lama left against medical advice. So nowadays, even neurosurgeons inform that the opening of the head is dangerous. This is not right, because you should, if you cannot open the head in safe way, then you should do something else than microneurosurgery. So there are many routes that go to Rome. You should take the shortest, cheapest, and best one, many times clipping, MC aneurysms, and many other aneurysms. Here is from our database, 22,000 aneurysms, some aneurysms that might be very suitable for microsurgery, large, giant aneurysms, middle cerebral aneurysms, more than 6,000 cases, patients with large intracerebral hematomas, hydrocephalus, and aged patients might have very tortuous vessels, difficult for endovascular surgery. So small MC aneurysms, they are superficial and simple for clipping, difficult for endovascular surgery. And anyhow, there are many difficult, or like Dr. Drake, my teacher, called impractical aneurysms, like here, giant thrombosed vertebral aneurysm, calcified aneurysm, and I will show more of them. This calcified MC aneurysm need bypass surgery. Giant tumor-like MC aneurysm was resected and clipped in a Jehovah's Witness, not accepting blood. Take a look, good flap, not a small flap for this case. And then you have patients with hematomas. This is young male, had 4 bleedings on Monday. Finally, in emergency room, both pupils dilated. I went to operation room, took the hematoma out and clipped the ACAM aneurysm, and the patient made recovery like miracle. Is not able to work as taxi driver, but is able to take care of his 3 children. So what is the future? At the moment, only 2/3 of the world population have, 1/3 have access to endovascular surgery. I think in future, we will have biological solutions to treat the aneurysms, and of course there is prevention. So China is a huge country, 5 times bigger than USA population, and here the aneurysms are common because of the male smoking and fatty food in both genders. So it is 7 to 10% of the population are carrying unruptured aneurysms. In USA, maybe 1 million people are running with aneurysms. So the price of pipeline here in China is very high as compared to clip. So I think like COVID-19 stop traveling, maybe the high cost of endovascular treatment will reduce its use, and it can be seen already in bigger populations. Maybe the prices go down. This every year has been told that the prices go down, but it is very difficult to afford endovascular treatment to the huge number of patients with aneurysms. So, are you still clipping aneurysms? I think there is big need to continue clipping, because for me, this is the best and most durable aneurysm treatment in skilled hands. And skilled hands might be rare nowadays, but the perfect clip around the base of those deadly sacs remains extremely good treatment if it can be put in the place. So for the good treatment, you need good team. You are not doing alone. Here is in our hospital, good scrub nurse, ping, and good anesthetic team, and this gives you good results. So about the annual surgery videos, all of them can be seen free in internet. You can search by Hernesheim 1001, around 1,600 videos, and the Helsinki microneurosurgery book in many languages can be also found there. My student Behnam Jahromi is now finishing his PhD book on these monstrous aneurysms. He has huge collection of these atherosclerotic giant aneurysms, 519 cases, and the book will come next year out. We developed slow closing clip for treatment of these terrible aneurysms, which resist all kind of treatments. So I thank you for your attention, and kiitos seisei.
Thank you very much, Juha, for this comprehensive presentation covering part of your experience, and thanks for sharing your experience. There is no questions. Look like people, they are just listening to this marvelous experience. I have
there's just one question come up just while you were speaking, I think.
Yeah, let me first give my question and then we'll go for this one.
Perfect.
I want to ask you, Juha, we have here your friend and counterpart on the intervention, and Professor Jacques Moret from France. He joined us here on the webinar, and you have collaborated. Yeah, you have collaborated with him. I know that time from your time in in Scandinavia. In which situation you have referred cases for him to do interventional radiology? What are the cases you felt you don't want to touch it? I know you have vast experience in many, but I'm sure there are some cases you elected to seek his role in the management. So what are the cases?
When we were sitting in Helsinki in operation room, both of us were saying that we can treat 100% of the aneurysm. That was the situation. But of course, we had difficult cases. Jacques Moret came to help in AVMs and aneurysm to Helsinki. This was the way. Usually it was more simple for him to come to Helsinki than for us to send the patient to Paris.
Can you give us, for the sake of the trainees, they understand what difficulty even the most experienced person in aneurysm surgery, that he is obliged sometimes to move some to intervention management? Which are the cases you have referred to him that you felt they are not going to be the best treatment by clipping?
During my time, all cases were done by open microsurgery, except I was traveling, then they had endovascular treatment.
So you have not referred to him any cases unless by default?
There are also, of course, there are also endovascular surgeons in Helsinki, and now they are very florid. They're doing a lot of cases, more than clipping. So this is, of course, the spread out, and for many reasons. So I showed in one slide that during my time, 95% of the annulus were clipped, and then nowadays only 1/3.
1/3. All right. So we have one question. Go ahead, Sanjeeva.
I think it's a question that's come from a Dr. Harshad Parekh, and it's a general question, I think for Professor Hannes-Niemi and Professor Kato, asking, in giant aneurysms such as giant basilar tips, when would you advocate bypass surgery? I know it's very case specific, but the question has come in quite a general manner. What are your thoughts, Professor Hannes-Niemi, Professor Kato?
I think the basilar bifurcation annulus are not good for bypass surgery. You have to clip them or then treat with the present endovascular means with the different stents and coiling. But one of the difficulties in basilar tip or other giant aneurysms that they are usually they are recurring and they are pressed inside the brainstem. So you might have pushing more and more coils, and then they grow inside the brainstem. So this is the difficulty. It is, of course, like I showed the case of clipping a basilar bifurcation annulus, it is not easy. And I was questioning if I can do it again all the time, or if somebody can learn it. So it needs a long training and also good surrounding, supporting surrounding for that. So it means
any
team
question? Oh, sorry. Any question from the panelist or comment?
I think Prof. Kato wanted to say something.
Yeah, Professor Kato.
You have shown us a very attractive, the giant vaginal tip aneurysm, but I think that recently so many stents is coming up. I think so no more coil compaction, or I think those type is we should always think about the perforators, and also of course the bypass is the way we can survive with the perforator function. I think. That is one of the ways we can save the perforators. But I think many at the end of us advancement we should appreciate. I think. Thank you.
I didn't say anything. I said that if I can do it again, or someone can do it again during these times. Times have changed. The pressure for endovascular surgery is extremely hard. Even sometimes they recur, and it is not so easy. Of course, perforators must be always saved. Basilar tip. So if you hurt one perforator, the patient is invalid.
Thank you.
Is invalidized, bedridden.
Imad, may I make a comment?
Oh, sure, yeah.
Compliments your wonderful presentation. One comment is about how to teach young people. The big problem everywhere is that easy aneurysms to be clipped are not more in the hands of our young colleague. That is the main problem. So they have to learn vice versa. They have to start with bypass, with complex aneurysm, and go back to the complex normal size aneurysm. That's my comment. Anyhow, comments to you and for what you taught us in these years. Thank you.
Thank you. That's a very valid point you mentioned, Giovanni. All right, I think we'll move.
Wants to say
yeah, go ahead. Yeah, please go ahead. Johan,
okay, can you hear me?
Oh yeah.
Okay. Yeah. Good morning, everybody. It's nice to see you, and it's nice to see again my friend Jua. So I'm not going to comment on what Jua said because I never fight with my friend. But he raised a very nice point. But in other way, I will answer the question in my talk. I think the main question was already raised. How can you treat neurosurgeon today? There is less and less aneurysm, and of course, less and less neurosurgeon to do it. So it's a crucial issue. I think you should copy or mimic what the American neurosurgeon did. not necessarily because they wanted to do it, but it was necessary because the business is going to this point. Why don't you do it? Learn it. Send your young neurosurgeon and learn the technique. And then you will again master the field. And having the possibility to be on both sides means that you are not going to choose between a given technique and another one. You will just do the one you think is the best, and very, very soon you will go for endovascular 80%, 90%, and 100%. So I think one of the ways to avoid keeping fighting for nothing, which is completely stupid, you better think about having one single discipline, which is, neurosurgery or endovascular, or maybe neurological surgery. So you can avoid speaking about endovascular or interventional neuroradiologists or neurosurgery. You speak about neurological surgery. And in neurological surgery, you have open skull surgeon and endovascular one. It should be one discipline. It's completely stupid to continue to have two disciplines fighting together, which is useless, and it's not part of the future. The future is already having one single discipline, and for endovascular treatment, it will be the key and the point for treating aneurysm, even now, but in 10 years from now, forget about surgery, forget, honestly. So this is our goal, to sit all together and to build up one single discipline.
Thank you for your comment, Jack. Okay, I'd like to move the moderation to my co-moderator, Professor Sanjeeva from the Oxford group. He's heading the skull-based training program and the residency training program there, and he will share the next presentations.
Hima, thank you very much, and thank you for a great session so far. I'm very pleased to introduce the next speaker, is Dr. Baskaya, who is a professor of skull-based and vascular surgery at Wisconsin, and has a great track record in skull-based and vascular surgery. He'll be talking to us about approaches to cerebral aneurysms. As you know, he has extensive experience in this area of the WFNS committees, the AANS committees for cerebral vascular surgery. So very, very kind of you to come and join us today, Professor Baskaya. Please share your screen and start to talk, and thank you again for joining us.
Thank you very much. Thank you, Sanjeeva, for your kind introduction, and Imad and Vlad, thank you for having me, and distinguished speakers. I see friends here, Juha, Kato, wonderful talks. I'm not going to make any comments about endovascular versus open surgery, but I think they shouldn't be competitive in a bad way. They should be collaborative, and so if you have both good, I think as a department you'll do good. So my talk is about the technical aspects of the surgery. My understanding from the topic was talk about the general, how we approach the surgical approaches to the intracranial aneurysm. I have no disclosures, and in general we have these three main options for the open surgery for intracranial aneurysms: clipping versus clip reconstruction, or bypass and trapping. There are so many other modifications. I'm not going to go over that, but I'll show some examples how we approach these aneurysms. And basic tenets of the intracranial microsurgery, in particular cerebrovascular surgery: when you are doing this open surgery, no retraction or minimal brain retraction, brain relaxation by wide arachnoid dissection, and obtaining the proximal and distal control early and always, and maximal safe exposure. And I don't like getting stuck with the fancy terminology like trans hair. I don't have hair, but trans hair follicular. I clipped this from a giant aneurysm. I think minimally invasive is the poison word, and we should use maximally safe methods, either endovascular or open surgery, whatever is maximally safe in your hands, please do that, especially the young colleagues and the residents. How do we approach to anterior circulation aneurysms and some posterior circulation? We have workhorse of the intracranial microneurosurgery is the terminal craniotomy, and you can use this and or its modifications like UHAS supraorbital or other modifications and clip many of these aneurysms from way anterior communicating artery to the proximal pericallosal artery, all the way down to the superior cerebellar arteries. And then you can use cranioorbital approach, skull base approach in some selected cases, not every cases you need to do, but you need to be versatile as a neurosurgeon. You cannot just stuck with one approach and you always do that. So if necessary, you can do subtemporal approach. If necessary, you do terminal transsylvian approach or combinations or modifications. For again, subtemporal craniotomy for pericallosal aneurysm, you can use anterior interhemispheric craniotomy. These are all well-known approaches and very conventional approaches. So I'll show a couple of examples, starting from way proximal paraclinoid region and then go to the MCA. Paraclinoidal aneurysms are tough. When you deal with the paraclinoidal aneurysm, you need to be versatile with your skull-based techniques. I always use terminal craniotomy. I don't do cranioorbital approaches unless there's a specific need for that particular case. And just conventional craniotomy as described and introduced by Yaşargil, and many modifications introduced later. But anterior clinidectomy, intradural versus extradural, is another matter of debate. I start with the intradural and slowly switch to the extradural clinidectomy. To me, clinoid is a extradural structure. So extradural clinidectomy is much safer, in my hands at least, and is more anatomical. So how we do it, we elevate the dura like Dolench described, dura propria, and elevate enough to expose entire clinoid, and then start with the optic canal drilling, then eggshelling the clinoid process, and then removing it. And you need to pay attention to the pneumatization of the sphenoid sinus and the other things. So this is an example mistakenly diagnosed as a posterior communicating artery aneurysm by our radiology colleagues. And 61-year-old patient want to have the surgery because she has a history of cancers, and if she needed to procedures, using the anticoagulation will prevent those kind of complicate those kind of procedures. So this is the again extradural anterior clinidectomy and eggshelling, completely disconnecting, making sure it's completely disconnected, then going intradural, opening the proximal sylvian fissure. As you see the distal aneurysm, and this is the posterior communicating artery, oculomotor nerve, and distal dural ring, and cutting the falciform ligament initially, then excising the distal dural ring, which is essential in this very important step in this aneurysm. And you see the transition from oculomotor nerve entering the oculomotor triangle and excising the distal dural ring, and I had to leave the tiny attachment here, and obtaining the proximal control and distal control, now clipping, and the rest will come with the multiple clips, more clips, and it's kind of broad-based aneurysm. So again, paraclinoidal aneurysms is you need to be very competent dealing with the skull-based approaches. Skull-based anatomy is very important, and adding the clinidectomy is crucial in these cases. Same as the ophthalmic aneurysm, amount of the clinidectomy is questioned. If distal located ophthalmic aneurysm, you don't have to do extensive complete clinoidectomy, but proximal locating aneurysm, you better do it. This is the example of that case when you need to do a complete clinoidectomy again, a complete extradural clinoidectomy, and Dura protects the brain from the manipulation of with the drill or any other things. We know rarely you can have the catastrophe of these, and removing the last piece of optic strut, going to the then the rest is arachnoid dissection, and opening the proximal fissure will help you to relax the brain and minimize the brain retraction or eliminates the complete brain retraction. And I'm going to skip these parts. This patient has two aneurysms, ICA bifurcation and ophthalmic. That's the reason we elected to do, because small ICA bifurcation aneurysm was not amenable for any kind of endovascular treatment because there were perforators coming off the dome of the aneurysm. So that's the beauty of the open surgery. You can change your things, and by seeing it, you can modify your clipping or surgical techniques. So this is the ophthalmic part, and I'm going to go show you the bifurcation. Again, the basic principles: proximal control, distal control, if necessary, open the neck. And if you drill the clinoid completely, you can have a clinoidal ICA as a proximal control. If you are not comfortable, do both. And this is the small aneurysm. So perforator is coming from the neck of the aneurysm, and one perforator is coming from the dome of the aneurysm. So open surgery will allow you to tackle both, and I don't know who will be against it, but so the distal, cutting the vas from ligament, cutting the distal dural ring. In this case, is complete excision of the distal dural ring is crucial. Otherwise, your clip won't close, and it takes time, and you need to be again. So you see the ophthalmic origin, a broad base aneurysm, and distal aneurysm, freeing. This will also allow you to manipulate the optic nerve freely, and further cutting necessary, excising the distal dural ring. So then finally we see the part of the aneurysm actually almost extradural. So then we are getting ready for the clipping now. So once we free this, now we are, I'm gonna put the, I think I put the temporary clip already. So last piece of the attachment in the distal dural ring. And then the clip reconstruction of the broad base aneurysm, preserving the normal anatomy. And then the you see the ophthalmic origin is preserved, aneurysm is free, and different clip applying can different clips can be applied, and so the crashing the neck, and with some stenosing of the ophthalmic the ICA, and we achieve the complete, and that's ICG shows you that, and then the rest is the being actually little creative with this clipping, preserving this branches coming off the dome, and same time crashing the aneurysm with one micro clip. good angiographic results, good clinical outcome. And you see the stenosis because what that was intentional. And we also get this kind of aneurysm. This is it's hard to know what is the true origin of this aneurysm, but it involves the supraclinoid ICA 360-degree fusiform aneurysm and multiple attempts of endovascular stent placement, flow diverting 2 sessions, each took 14 hours by 3 different endovascular colleagues. So who's going to do this now? Progressive vision loss. Who's going to do this 10 years from now, 20 years from now? What technology? No technology. I heard these like 20 years ago. Oh, 10 years now, 5 years from now, everything will be endovascular. No way. You see, you have to do bypass. You have to prepare for the worst. This is a high bifurcation. So instead of external carotid, we're going to use the common carotid, radial artery harvest. And you're going to need vascular neurosurgery for skull-based tumors. You're going to need vascular surgery for gliomas of the insula, thalamus. And when you run into trouble, when you explode the N1 during the balloon angioplasty, you will need the vascular neurosurgeons. Okay? We are not going to go away. We are here. So what we did, bypass, trapping, and then the clinoidectomy to preserve the ophthalmic artery, preserve the anterior choroidal artery. These are the key things in the surgery. And when you are doing these surgeries, you should be able to do any kind of bypass, in any location. Once the bypass is in place, we have to do the common carotid because bifurcation is high. So we learn from the other disciplines also. The aortic punch can be used to make a very nice hole in the common carotid. And we're going to do that. You'll see. And very atherosclerotic artery, you see the layers of the thing. I'm going to go even cut more and then finish that, finish the bypass, go to the aneurysm, complete the clinoidectomy so I can preserve the ophthalmic artery. I'm on call and they keep paging me. I'm sorry. So once you get the proximal control, you can put the first clip, trap the aneurysm, and then take the clip off to the ICA in the neck. And then puncture the aneurysm and decompress. Angela, can you call Access Center? Tell them I'm on the webinar. Take care of the call. Okay, bye. Just call them. Thanks. Sorry. And that's it. Aneurysm is decompressed and good outcome. Perfect. Except she had a superficial infection of where we harvest the radial artery, and her vision got slightly better, but not completely better. So giant aneurysm. I don't know how we're going to do this with the endovascular means, but you need to decompress. You need to be prepared. ICA bifurcation is 8 centimeter aneurysm, and you need to treat this like a tumor and the vascular problem. Decompress the thrombosed parts, do the complete thromboendarterectomy, and get the proximal control. Simple craniotomy might be important, but due to the mass effect, I had to do the cranioorbital, so I didn't want to deal with the brain swelling and exposing the ICA, anterior cerebral, ventricular striate, anterior choroidal, and then when you get to the live portion of the aneurysm, go for the temporary clipping, and you're going to cause the bleeding. You see that this is the thrombose part, but it is fresh thrombus. So now we are ready for the final part, minimizing the temporary clipping. And this is old video, and crashing the aneurysm is important for the young guys. Don't be very ambitious with this part of the aneurysm. These are thick wall aneurysms, giant aneurysms, so you can cause many problems. So his aphasia and the hemiparesis improved over time, and 1 year is perfect outcome, has been stable with the stable residual neck here for at least 6 years. A1 aneurysms, again, simple craniotomy, terminal craniotomy is best for this partially thrombosed, large aneurysms, and Sylvian fissure opening, proximal control, distal control, and you have to use some sort of retraction here. See how it is attached to the optic nerve. She has visual problems, and we are localizing the Hübner, and now under the temporary clipping, I'm going to open the aneurysm. Do the thromboendarterectomy until you get to the live part of it, then apply the pilot clip. Once you apply the pilot clip, you can mobilize more, and little opening in the neck. Dopplering. We are not going to finish there. We have to decompress the optic nerve and make sure distally A1 is filling too, and an A1, A2 junction, and further removing the thrombose part, so you don't have and completing the thromboendarterectomy is essential here. Otherwise, you don't know it's stenosing the anterior cerebral artery. All the efferents and efferents are fine. Final piece, good angiographic results and good clinical outcomes. ACOM aneurysms, I like to do just conventional terminal craniotomy, but in high-grade subarachnoid hemorrhage cases, swollen brain, a cranioorbital approach helps you to minimize the brain retraction. Again, is optional, but this is the video to show you the difference between this is when the supraorbital bar is in place, this is without it. So it's a tremendous addition. You can argue, I know you will be upset with me, but it's a lot. And I've done this 1,000,000 times, and this high-grade subarachnoid hemorrhage cases is the best. This is a grade 5. And many people won't even touch these patients, but I have a large series of grade 4s and the 5s, and our results is better, but I cannot get it published because it goes to the endovascular colleagues and they reject. And this is the grade 5 subarachnoid hemorrhage, emergency surgery, wide opening, lamina terminalis opening, ventriculostomy, wide craniotomy. Don't be dogmatic about craniotomy size. Do whatever best for that patient. And the wide arachnoid dissection principles set by the Yaşargil. When you are doing ACOM aneurysm, you need to see 13 arteries. Then you are not doing the safe surgery. Clipping, pilot clipping, cutting the aneurysm until you are satisfied 100%. You had the complete clipping. I'm not happy. I'm going to puncture. I'm going to even cut the aneurysm. So there's tiny branch on the back wall of the aneurysm. This branch, I need to make sure. Should I Can I take it? Maybe I can take it and nothing happens, but why should I? And if we can do it, we should be perform the perfect clipping, preservation, all normal anatomy, and exclusion of the pathological anatomy. And believe or not, he made an excellent recovery. This is 60, nice Wisconsin farmer. Okay. And same, clipping, coiling, 3 years later, recurrence, aneurysm is getting bigger. It was grade 5, now improve. And these are, you don't want to just keep pushing the coils inside. Just, if they talk to me first time, and you see many of these coils outside. So anyway, we clipped this with the fenestrated clip, nice results, no worries about the recurrence anymore. It's been aneurysm free for many, many years. MCA aneurysms, just simple internal craniotomy. You don't have to be genius about this. It's just, and this giant aneurysms, you're gonna get these aneurysms, simple or complex. Somebody has to do it. You cannot do, either you do bypass or clip reconstruction, but you need to be prepared for both. You just can't go there to clip reconstruct this aneurysm. You have to prepare for all kind of bypasses. You have to have A plan, B plan, C plan, even Z plan, okay? And then again, the same thing I show you. And once you get first pilot clipping, and then improving your clips by cutting more. And MCA doesn't tolerate too long temporary clipping, so you need to be quick, and monitoring is helpful. And then it's good training for the younger colleagues to do practice aneurysmography after everything is cool. And did perfectly fine. And all his TIAs or her TIA is gone. She didn't have anything. Again, we left the base here. That's the atherosclerotic calcified base. You don't want to be ambitious, but those bases don't grow. If you leave base endovascular, it will grow. There's a different physiology, different physics. Pericallosal aneurysm, same. Mass effect, seizures. Again, you have to, in this case, you have to do interhemispheric exposure and transsylvian exposure, the proximal control, interhemispheric exposure for the distal control, and you have to have the 100% control over the neck, fusiform neck, and then you have to decompress the aneurysm and be prepared for the bypass, A3, or superficial temporal artery to A3 interposition graft bypass, and that's what we did. You can watch this as published, as again as the same principle. Opening, if you feel that you cannot clip reconstruct, stop there, do the bypass trap. Young person, again, proximal pericallosal aneurysm, fusiform, partially thrombosed. One artery comes, the other artery comes out. This is very small compared to other, and there is a long distance between, so A3 may not be option. You can simply trap these aneurysms, but we did the dynamic studies and there's no posterior pericallosal collaterals. And what we are, then you have to do some sort of bypass. So we prepared for an STA, radial artery interposition graft. We prepare for A3, and we'll decide at the surgery. Wide arachnoid dissection, getting the proximal control, interhemispheric dissection, and checking the distance between two is almost impossible to bring these together without taking any branches. And no retrograde flow with the dynamic ICG, so the patient is not going to tolerate just simple trapping. We confirm that. And estimating the STA, now we know that we cannot do A3. We're going to go to STA trunk to the A3 bypass and go that is very narrow space, very tight play area, but then the trapping the aneurysm. You see the interposition graft coming from the STA frontal branch because it was short. He's a boy, not very big arms. Radial artery was short. and we did the A3 bypass, and in 2 months he's back to school. Headaches are improved, completely normal, no neurological deficits. Posterior circulation is same. If I do the basilar aneurysms, in the past I did transsylvian terminal. Nowadays I do transcavernous approaches, and this is the one example. 2 aneurysm, multiple aneurysm. Patient is not compliant with these medications. He's psychotic. He works. He works in the supermarket, and normal citizen, but he doesn't like taking the medications. So how are we going to treat this aneurysm? Incidentally found after the head injury, improve after the head injury. So we need to do something. And this is the first, we need to address the large one, ACAM aneurysm, after doing the transcavernous anterior clinidectomy, extradural, all stuff. And we did I clipped the ACAM first, the largest one, and then move to the basilar, skeletonizing the oculomotor nerve, and in this case, small PCAM, perforator-free segment of the distal part of the PCAM. You can take it. It's high-riding posterior projecting aneurysm. You find the aneurysm, and then the basic principles: preserve perforators, P1 perforators, preserve the normal anatomy, and exclude the pathological anatomy. And there's 2 clip reconstructions after the temporal clip is kind of bulbous neck with the 2 clips. You see the perforators are preserved, and is wide exposure. You don't worry about the proximal control, contralateral side, and puncturing the aneurysm and crashing with the second clip, and you see all the perforators are nicely filling. So with one surgery, we dealt with the 2 aneurysms. Pike aneurysms is the same principle.
Dr. Bhaskar, I'm sorry to interrupt.
I'm finishing.
Okay.
Same posterior circulation, far lateral transcondylar approach. You'll have cases like this. There is no intraarterial access to coil this aneurysm and fusiform. Patient has previous strokes, peripheral arterial disease. What you gonna do? Nothing, other than coiling, recurrence, clipping. High riding pica, retrosigmoid approach. You cannot do far lateral. So at the end, we come to the beginning point. We cannot do many vascular surgeries anymore, but we are intracranial microneurosurgeons. Tumor surgery, you do like a vascular neurosurgery. You eliminate the vascular supply to GBM, that's the vascular. You are doing like AVM. And meningioma surgery, everything is intracranial microsurgery. You can keep up with your microsurgical skills by doing intracranial microsurgery, not only vascular intracranial surgery, but also go to the lab, younger guys, spend more time, not 1 year, 2 years, 5 years, still go to your office, suture in the office, okay? Future is whatever you hear from the others. Future is still microsurgery. You'll keep the microsurgery alive. And thank you. Sorry for taking your time. And it's a busy day for me. I'm happy to take any calls anytime.
Thank you very much for an excellent talk. And I think for our more junior colleagues joining us, a lovely demonstration of how you deal with the distal dual ring and how it attaches to the adventitia of the carotid. I think there are some questions in the text. I know you're very busy, Dr. Bhaskar, but if you could maybe answer the questions by typing in there for them. Sure. While we go to our next talk, that'd be very, very helpful. But thank you for an excellent presentation.
Thank you.
And before I introduce the next speaker, I'm just going to take a short amount of time just to say happy birthday to my co-chair, Professor Imad Kanan. Happy birthday, Professor Kanan, on behalf of the WFNS committee.
Happy birthday to you.
Thank you. Thanks all. The best birthday to have this webinar, the inauguration. Thank you.
Not at all. And before I hand back to Professor Kanan for the last few speakers, I'll just introduce the next speaker, Professor Soichi Oya. We're very pleased that you could join us today. He has a huge experience, again, like all our speakers. He's joining us from Japan, a huge experience in neurovascular surgery. He's going to take on a very complex topic on giant aneurysms and the nuances of treating them. Very lucky to have him with us today. So thanks again for joining us, and please share your screen and start your talk. Thank you.
Thank you. Let me share my screen. Just a minute. Are you seeing my screen? Slides?
Yes, we are. We are. Thank you.
Okay. Okay. Thank you. It's my great honor to be able to join in this wonderful, the webinar. It's not easy for me to make a speech after such a distinguished giants in the world of neurosurgery. However, different from other, previous speakers, I'd like to share my complications related to the treatment of giant cerebral aneurysms. Giant cerebral aneurysms are hard to treat. Previously, incomplete occlusion was reported to occur in 11%, and the neurological deterioration also occurs in 22%. What's more, surgical mortality is reportedly higher than 10%, even with express hands. Today, I'd like to focus on clipping for giant aneurysms because, for example, trapping of the ICA aneurysm, trapping of the ICA with a radial artery or saphenous vein graft has already been established well for these aneurysms like IC cavernous giant aneurysms. So let me share the lessons I have learned through my failure, complications, and good outcomes. The first case is an example of my making a wrong judge intraoperatively. This patient had a ruptured left distal PCA giant aneurysm. What I intended was to remove the clot inside the aneurysm first and put multiple clips in a parallel fashion. If it was not possible, the plan B was to trap the aneurysm here and also the distal outlet here, and use the STA distal PCA bypass. So I used the left side transzygomatic subtemporal approach. I always put the screw and the plate like this before, reflecting the zygomatic arch, and I try to create as widely as possible this subtemporal working field. Now I'm cutting the tentorium. This is the fourth nerve, and I try to widen this working space. And this is the oculomotor nerve and the proximal P2 and the distal P3, and put the temporary clip to the proximal and the distal portion. And now I trap the aneurysm. And as my plan A, I incise the aneurysm and try to remove the clot. However, the clot was so hard. It was sclerosed, very firm. So I had to, give up my plan A. However, I observed when I released the distal temporary clip, I felt that the collateral flow was sufficient. So I decided to simply trap the aneurysm. And the ICGVA showed a good flow of the cortical arteries.
Billy.
However, on the next day of surgery, the patient had a lower infection in the PCA territory, requiring the decompressive craniectomy and leading to the poor outcome. So I learned we need to reconstruct the parent artery no matter what. So the second case is an ACOM giant aneurysm causing cognitive dysfunction. Look, this aneurysm appears to have a narrow neck here. You may think that you might be able to insert clip to the neck but we don't know what the aneurysm wall is like until we actually see it. It's probably thick and hard, and it's also might be partially calcified. So my plan is A3 bypass first, followed by left STA, radial artery, distal A3 bypass, and trapping of the aneurysm. So now I'm preparing the radial artery graft. And then I harvested the STA. And the left side frontal craniotomy was made. I cut the forks and opened the interhemispheric fissure, and I resected the forks so that I can get the wider space. This is the right side A1 proximal portion, and the distal A2. Aneurysm is here. It's buried in the brain. So then I moved posteriorly to find the distal A3 like this. You know, in order for you to complete this deep bypass successfully, I think the clean operative field is essential. So I have to avoid the contamination of the working field with blood coming down into the deep area. So by doing this, you are sure that you are making right stitches. And of course, it was repeatedly, stressed by the previous speakers. I think the practice or training is very important to safely accomplish this formidable bypass. Now I'm using the running suture in the deeper side, and I am expecting the patency larger as time goes. So I use the interrupted suture on the shallower side. This side, I use the interrupted suture. And the anastomosis, it looks good. Okay, then I harvested the radial graft. And now I'm making the radial artery graft bypass to the this more distal A3 portion. The difficult part of the bypass like this is that you do not have enough space to lay down this thick RA graft from right and left or left and right. You know, the big graft in deep working area usually makes it difficult for you to, directly see the interface between the donor and the recipient. And then I'm connecting the RA graft to the root of the SCA. And I confirm the patency. And then I approach to the proximal portion of the aneurysm. This is the left side A2. I apply the clip to occlude this vessel. And the right side, this is the right A1. And I cut the aneurysm wall. And while removing the clot, I had a bleeding from the distal A2. So, I already prepared the bypass to the distal ACA area. So I just applied 2 clips and the aneurysm trapping was completed. And the patency was confirmed again. And I returned the bone flap and closed the wound. However, post-operative angiography showed bypass occlusion like this. As you see here, bypass occlusion here. I speculated that this is because the compression to the graft by the bone flap. But luckily, he had a good amount of a collateral flow from MCA or PCA, possibly due to chronic hypoperfusion of distal ACA. So he had no infection in the distal ACA area and returned home in a stable condition. The next case is a giant serpentine M1 aneurysm. It was larger than 8 centimeters and causing right hemiparesis. And to our surprise, during his admission for elective surgery, he suddenly collapsed in the ward, and their CT scan showed bleeding from the aneurysm. So, it was a slim hope because he was diagnosed as a grade 5, but we conducted emergency surgery. So our plan was splitting the STA into 2 parts and connects them with RA graft, and making 2 anastomoses using the distal STA as a Y-shaped graft for M2, and then trap the aneurysm. So this is the left side, front temporal craniotomy. And there was a thick blood clot in the arachnoid cyst. And after removing the clot, I found this is the M1, M2 junction, and these are the M2 branches. And first, I need to confirm the condition of the ICA, because I was planning to occlude the ICA, but the wall of the ICA was soft enough for me to apply the clip. That's good. This is the A1. So I prepare the STA. This is just a facial branch. And then I prepare the radial artery graft. And this is the Y-shaped portion. I cut the STA at the root. This is the Y-shaped graft. And using the RA graft, I extended the graft length using the RA graft as a interposition graft. During this procedure, I think we'd better fill the heparinate saline with the heparinate saline, fill this graft to avoid the clot formation. And at the other side, I anastomose these 2 vessels, and these are the Y-shaped graft, and this is the M2. Because of this was a huge aneurysm, so the space was narrow, and this is not the brain. This is a very thick or stiff wall of the aneurysm. So the space was like the interhemispheric fissure. It's very narrow, but luckily I could complete the anastomosis like this. We need to keep clean the operative field. And first is done, and the second is go, and then now it's done. It looks good. A good precision, and also the ICG-VA show the good patency of both branches. And then I apply the clip to the ICA and M1 and M2 and complete the trapping. Okay. And but the CT scan taken immediately after surgery showed the infarction because of the probably initial damage of SAH, subarachnoid hemorrhage. He suffered from a bilateral MCA infarction. Although the aneurysm was occluded, the outcome was not good. So this time, based on our previous failure, we made a little change, which is gathering for a thick radial artery graft, as shown here, to preserve the patency of bypass. And the next case, this woman had a right giant MCA aneurysm causing declining cognition, partially thrombosed. So for this patient, we, created the STA, STA-MCA bypass first, and then I incised the aneurysm. And again, the clot was extremely, hard, and I could not see anything behind this aneurysm. So the first thing I have to do is to make this aneurysm smaller. So I'm, removing the clot, and this is the M1. I could get a good exposure. I'm just practicing the applying the temporal clip to the M1. And but I could not see inferior trunk of the M2, but I found the superior trunk of the M1, so I put the clip because we already made a bypass, and I could take time to remove the clot, and finally I had bleeding from the M1. So after controlling this bleeding, just like I practiced before, I applied the temporal clip to the M1 as distally as possible to preserve the renticulosteroid arteries. And these bleeding are from inferior trunk of the M2, but that's minor bleeding, so I could continue to deal with the removing the clot. And now I'm resecting the aneurysm wall. The important part is to reconstruct the M1 using this aneurysm wall. So I use this large long clip and use the multiple clipping method like this, using a variety of shapes of clips. And the patency was good. The Doppler sonography showed a good patency. And also the video, ICG video angiography showed a good, good vascular flow. Okay, I put another 2 clips. And there was no infarction of the post-operative MRI. And as you see here, in this case, I could nicely reconstruct the M1, and she returned home in a good condition. And I'm going to skip this case because what I want to say through this case is about the same. But let me just cover quickly. You see, this is a very big aneurysm. I use the bypass. The bypass is very useful. And I have to remove the clot like this to shrink the aneurysm. See, and same. But this time I could get a very nice aneurysm wall here. So it's almost healthy. So I could obliterate in much more simple technique. And she returned home with no neurological deficits. And this is the last case. He was a 12-year-old boy who had a severe headache while he was playing baseball. He had a partially thrombosed right M1 anterior temporal artery aneurysm. And this was a formidable case because the range of the temporary occlusion involved the renticular-storied arteries. So I have to get the procedure done very quickly. I cut the anterior temporal artery here. So these bleedings are from our renticular-storied arteries. But the the M1 is temporarily occluded at the proximal portion and the distal portion. So I just have to repetitively release this occlusion again and again. And I try to apply the clip here because it looks possible, but as you see here, because of the form wall of the aneurysm, the clips slipped in and make the stenosis at the origin of the M1. So I changed my strategy. I try to remove the clot as quickly as possible. And now I could make the aneurysm smaller enough, so I could put the clip at this line. But still, there's some leakage here, so I just I change a little bit. And for this type of large clip, you have to reinforce this tip area because the clip might not close enough. So I put another 2 clip. And our ICG video angiography showed a good arterial fall. And the patients went home in a good condition. So these are surgical nuances for giant aneurysms I introduced today. We need to make the most of vascular reconstruction technique. And we should be familiar with multiple clipping technique. And also we have to understand the clip characteristics. And in my opinion, we should not expect that you can do a simple neck clipping. So just like Dr. Baskaya said, we need to have multiple solutions. And you need to prepare for the sclerosed thrombus. As is often the case with partially thrombosed aneurysms, the intra-aneurysmal thrombi may be extremely hard. So you better get cursor, drill, and bigger suckers and scissors ready in the OR. Thank you for your attention.
I think Professor Sanjeeva has some appointments to leave, and I'm going to take over. I'd like to thank you, Professor Soichi. I'm not seeing any question on the chat, but we'll open the question and comment for the panel. We can take 1 or 2. Please feel free, whoever has some comment. I'd like to thank you for giving that presentation and show some of the complication and how to handle the complication when they occur. And bypass is, of course, is an essential procedure that the residents should learn to do early in their practice, because if they start doing it late, they will miss the train. And I think this is an important component. If there is no question, I'd like to welcome.
Can I say something, Imad?
Yeah, okay, you are with us. Go ahead.
Yeah, I came back. I had emergency. Imad, first of all, happy birthday. Many, many years with us.
Thank you.
Thank you for organizing again. And Oya Sensei, beautiful presentation. Wonderful.
Thank you. Good to see you again online.
See you. Thank you very much. And you stressed very, very important points. And thank you for your honest, candid presentation.
Thank you very much.
Mustafa.
I also learned a lot.
All right, I'd like to invite our next speaker, Professor Jacques Moret. He is the world-renowned interventional neuroradiologist. His contribution to this field is unbelievable. I have witnessed most of it because I mentioned that I inaugurate and dedicate that session to Professor Pierre Lajoignes. I'm sure he is a close friend to all of us. God bless his soul. And Professor Moret has contributed to education and teaching of a new generation of neuroradiologists, even other disciplines like a neurologist, to bring them into this field. He has contributed to the advancement in that field and by innovative ideas. And this is where we are now with the interventional radiologists. Without any further ado, I'd like to ask Dr. Jack, who is the chair of the Vascular Center in Bijon. How you pronounce it in French? Bijon?
Bicêtre.
Bicêtre. Oh, okay.
I switched to Bicêtre Hospital.
Oh, yeah. Bicêtre. This is where
5 years ago.
Where Pierre Lajoignes used to.
Pierre was. Yeah, this is what Pierre was, and this is where I did my medical study too with Pierre at the same time.
Yeah, it's wonderful. So please, the podium is.
Okay.
Share your screen.
I will.
We see your screen.
Is it okay for you?
Yes. Very good.
Okay, so this is the old hospital I'm working with. It's a hold from outside. It's very brand new from inside. Basic principle. Again, I'm not here to, put oil on the fire, but just some basic principle each time you see a patient. Nobody wants to have the head open anymore. That's a problem, but it's a fact. Endovascular treatment gives good result and it improves every year, which is also a fact. And another fact, it's more and more neurosurgeons do endovascular. They change their culture, and I think this is a good point. Having said that, let's have a look to what has happened to our discipline since 1975. This is what I call the obsolete treatment, the mature treatment, and the under-evaluation treatment. So let's stop about the balloon selective occlusion and the flow disrupture, and let's have a look at what we call the mature treatment, which is coiled, self-expandable, mixing of both, flow diverter. And I will add also the endosaccular device, which is a web that we are using since 2012. So it's not anymore a new treatment, it's a routine treatment in our daily practice. The guideline for selection of appropriate interventional neuroradiology approach is just based on few things. Your own philosophy and experience, it's absolutely important. Sometimes you are in a situation where there is no other reasonable choice, so you have to do endovascular treatment. And for the rest, it's at least 95% of the aneurysm, endovascular treatment is possible. So let's go quickly through what's possible with endovascular treatment, and then we'll see the potential concern that we might face in the other situation. So this is what we were doing in 1995. Wide stenting with wide balloon remodeling, with coiling of the aneurysm, having this result after the treatment. Today, we have much more fancy tool to do it. We can deliver stent, we can deliver braided stent in a wide configuration and stent in the middle and get this wonderful result after the treatment, whatever the size of the neck of the aneurysm. It's another middle cerebral artery aneurysm. I took those examples just to, fix exactly what we can do in a very typical neurosurgical indication. This is a kind of aneurysm that you don't really see clearly where the neck. It's a very ugly looking aneurysm, but if you reconstruct the wide division with wide stenting, it's not that difficult to put coiling in the middle and to get this wonderful result on a 3 months control angiogram. Another shallow aneurysm, again at the middle cerebral artery bifurcation, which is going around the bifurcation of the MCA. And again, with this proper selection of the stent, you can really do a wide stenting, put coil in the middle, get around the sac of the aneurysm, around the bifurcation itself, and finally got a very good result. Even the dissecting aneurysm of the pica, it's no more a real concern for us. We have the possibility to deliver a very small stent, to put coils in the middle, and even today, I would do this treatment with a tiny little flow diverter. So this is the kind of result you can get after the treatment with a perfect exclusion of the aneurysm. So just for you to show what we can do. Now, the technology is evolving and we have the possibility to use also this endosaccular device, the web device, which is in this situation where the neck is clearly visible and the sac is very regular, a piece of cake, you navigate, you drop the aneurysm inside, and you find this 18 months later, a perfect closure of the aneurysm and preservation of the middle cerebral of the anterior communicating territory. When the aneurysm, again, at the middle cerebral artery bifurcation is ugly looking with a very wide neck, difficult to think that it's possible to do it with an endosaccular device. It's not true. You can deposit the cage inside the sac of the aneurysm, that is done here, and then you check. We have the possibility with this fancy radiological equipment to look at what's happening with the device inside the sac of the aneurysm itself, and we clearly see that there is a small remnant at the level of the neck. If you leave this like that, you have a chance to get recurrence at this level. So you have to get rid of these potential factors for recurrence of the aneurysm. So it's very difficult to tilt the device inside the sac of the aneurysm. You can just pull and push on it. So one possibility to do it is to put a balloon at the bifurcation. Here you can see the balloon is inflated, then very progressively you deploy the web, and then you pull on the web. And by pulling on the web, as you can see here, you will see, puff, it tilts towards the bottom of the aneurysm, I mean the neck of the aneurysm, protected by the balloon which is there. And having done that, you can clearly see the difference between what it was before and what it is after. There is a very nice apposition of the bottom of the web at the bifurcation itself. This is a wire of the balloon catheter, which was used to help this positioning of the web inside. And this is the follow-up. This is pre-op, this is immediately post. There is very frequently flow in the device immediately after the deposition. This is 1 day post, it's already almost completely gone. And this is 20 months later with a perfect occlusion of the aneurysm and a perfect healing at the bifurcation. Ugly looking aneurysm in difficult situation like blister-like, it's a concern for neurosurgical approach. It was a real concern for endovascular too. It's not really a concern anymore as far as we have possibility to use the flow diverter. And the flow diverter can be used in this dramatic situation in emergency to treat this aneurysm. As far as you care about the preservation of the patency of the ECOM, in this situation it was the case, you can just deploy a flow diverted stent covering the neck of the aneurysm and the branch, and even if it goes crosses the origin of A1 segment, it's not a concern as far as there is a cross flow. This is a flow diverter, this is the aneurysm, and this is what you can see 6 months later. Aneurysm is completely gone. The artery is completely patent. The lenticular striate is patent, as you can see here. And you can also see that here, it goes through the lenticular striate and the aneurysm is completely gone. Looking at the vaso-CT, which is a special way to screen on the aneurysm with a CT in the angio suite. So this is a 6 months post-op just to compare to what it was before. So even in this very difficult situation, we have the possibility to do treatment. So forget about what we can do in aneurysm that are competitive or not with a neurosurgical approach. I would prefer to insist on the fact that a lot of indications are only depending on our philosophy and experience. And there is one thing that belongs to philosophy, which is a bypass. The bypass is really an indication based on your own philosophy. I have nothing against the bypass. I just want to tell you that there is an endovascular way to go around the bypass and to avoid the bypass. So this is an indication of what we were doing previously, which is all this 10 years ago, before we got the flow diverter. This patient had a partially thrombosed bifurcation, carotid bifurcation aneurysm. And this patient was treated by parent vessel occlusion. We occluded the carotid. It was not done here, but I would have done the same at that time. And, on the control angiogram, the aneurysm is still filled, and the distal part of the middle cerebral artery is perfectly visible. So when you look at this at that time, we did a treatment based on bypass. A high flow bypass was performed, as you can see, which was good patency, which is also supplying the middle cerebral artery territory, and the patient was really nice. The second step treatment was to occlude the aneurysm, the carotid aneurysm artery, and at that time we decided to do a control angiogram before the treatment, and this is what we saw. This is the right side, and this is the left side. And as you can see, there is no more aneurysm visible. Definitely, the competition of the flow, this is a superimposition, is clearly showing that because of that, the aneurysm has disappeared. The bypass is supplying the middle cerebral artery territory, and the ECOM is supplying the anterior cerebral territory. So this is a good result. So what do we do today? Today, it's a different song. Let's have a look at this aneurysm. This is a typical aneurysm, dysplastic, ugly looking, a lot of blister all around daughter side on this dysplastic aneurysm. And of course, there is a possibility to occlude after doing a bypass surgery, but also there is a very simple way to do it, which is crossing the aneurysm, delivering a flow diverter, and this is what you get, a perfect reconstruction of the parent artery, and the aneurysm is gone. So this is really a tremendous thing. Let's have a look at this. This patient got giant aneurysm of the bifurcation of the carotid artery. He had a bleed at the time it was discovered, and he was treated 2 times by endovascular approach by coiling of the sac of the aneurysm in another approach. Everybody knows that this is not the way to treat a large aneurysm, and this is the recurrence of the aneurysm, wide neck, the portion of the middle cerebral artery, which is still patent and visible there, intricated with a bifurcation. So there is also a good indication for a bypass surgery, but there is also, as far as you have a different kind of experience, a possibility to just put a flow diverter crossing the carotid, supraclinic carotid artery to the A1 segment. As far as you bridge this, you just cover the neck of the aneurysm. So what about the patency of the middle cerebral artery? This is what's happening. Look at that 5 months later and 14 months later, aneurysm is completely gone. The parent artery has been reconstructed. And what's left from the middle cerebral territory is completely patent. So this is something that you have to, know it's possible to do this kind of treatment just by covering the bifurcation as far as you maintain a high blood pressure for a while. It's another example of a ugly looking aneurysm, dissecting aneurysm with an entry and 2 exit. As far as you check the potential collateral situation, circulation on one of those 2 territories, you can know the one that you can bridge and the one that you can potentially include in the occlusion of the sac of the aneurysm. We can navigate bypass. There is a lot of possibility to navigate inside the sac of the aneurysm and have a scaffolding and then deliver flow diverter in the scaffolding. This is the VASO-CT, which is clearly showing that this montage has completely covered the neck and reconstruct the parent artery. Now let's have a look at what's happening. This is 14 months later. There is still a little bit of the aneurysm visible here, of this large partially thrombosed aneurysm. And this is a 3D picture. And this is 20 months later. The aneurysm is completely gone. The parent artery, which is a collateral exiting from the sac of the aneurysm, has been completely preserved. There is still a patency and a flow inside, and no more aneurysm visible. So just for you to understand that this kind of difficult aneurysm, which is a potential indication for bypass surgery, is also a very good indication for intraluminal parent artery reconstruction, just for you to understand what it was before the treatment, and this is the patient after the treatment. Now, let's have a look at this difficult aneurysm. It's an aneurysm which is at the distal part of the carotid, supraclinoid carotid, just at the origin of the middle cerebral artery territory. This is the PCOM, as you can see. This is the posterior circulation. There is no supply from the A1 segment. And this is the injection from the vertebral that you can see. you inject retrogradely through the PCOM, the aneurysm. So basically the whole middle cerebral artery is completely intricated in this giant aneurysm. There is also a good indication for bypass and then occlusion of the sac itself or occlusion of the parent artery. But if you look at the anatomy, there is also a possibility when you go from the posterior circulation and then you come retrogradely through the PCOM and then you navigate in the first porch and then in the second porch and then you find the exit and you get access to the middle cerebral artery to do this kind of montage. This is a high pressure injection of the carotid. You can see the supraclinoid. This is the PCOM. It stops here. There is no A1 segment. And this is the beginning of the story of the aneurysm. And this is the opposite side just to understand the potential crossflow from the circle of Willis. So what we decided to do is to navigate from the posterior circulation this way. So of course you cannot do that with one single flow diverter stent. So you have to do scaffolding stent instead in a telescopic way, and 3 different flow diverters were delivered coming from proximal to distant. This is the coverage and the reconstruction of the parent artery. This is the section through the montage of the stent, clearly showing the perfect reconstruction of the lumen of the vessel. And this is a 6 months control angiogram. You can see that was expecting has happened. The PCOM is supplying completely the middle cerebral artery, which has been reconstructed, considering that the aneurysm is gone. So there is no question that we can do a lot of things, despite asking, or it's interesting to know what's possible to do. Then the choices, of course, depending on your philosophy and depending on your experience. In some situation, there is no other reasonable choice. It happens, and there is no question that it is the case when you are dealing with a cavernous carotid aneurysm, which is responsible of cranial nerve compression. Today, nobody thinks about doing something from inside. Everybody is reconstructing the parent artery by delivering a flow diverter stent in the carotid siphon to get this wonderful result 14 months later. Nobody can think that this patient had an aneurysm if you just look at this picture. So this is definitely the way to go. There is no question about it. Now, let's have a look at this situation. Think about the possibility to treat this aneurysm. Surgery, I don't think it's easy. Endovascular, it's not easy. Plus, you have to choose the proper tool. You know, there is a big concern in our discipline, which I hope will be yours one day. We have so many tools that it's difficult sometimes to choose which one is more suitable in a given case. In this situation, there is no question that having a wire reconstruction and using laser cut stent, one which is not open cells and one which is open cell, is extremely important. Why? Just because you know exactly how to protect and reconstruct the parent artery, and then you can go through with coils. So this is the aneurysm when looking at the angiogram, and this is the evolution of that aneurysm pre-op. This is immediately post. There is some dye going through the stent and through the mesh of the coil, and this is 8 months later, a perfect reconstruction of the basilar division, and the aneurysm is gone. So even in those difficult and critical situations, we can do something. Of course, we can do something in this ugly looking dysplastic middle basilar artery aneurysm. The real question is, should we do the treatment of this? I think today, with the kind of tool that we have, it's absolutely reasonable to do the treatment of this aneurysm. So the patient is treated very simply by delivering a flow diverter. The navigation sometimes is not that easy, but you know, this is our business, so we are not going to complain. Let's have a look at what's happening. This is after the treatment on the right side of the screen, and before the treatment, the basilar artery has been perfectly reconstructed. The aneurysm is gone. It's not difficult, and this is also one of the beauty of the tool. In most of the cases, it's not that difficult. I'm not saying that you don't need experience. Of course, you need experience, but it's not as difficult as, for example, neurosurgical approach. Let's have a look at this patient who can do something unless you use the tools of the Centauri, which is a flow diverter. This patient is 15 years old. She presented a sudden headache with vomiting, and the CT scan, which was done The next day was definitely demonstrating some bleeding in front of the pons. And we did an angiogram, and we noticed this dissecting aneurysm of the upper side of the basilar involving the superior cerebellar artery. How can you think that you will be able to do a treatment in these patients? There is something that you have to understand. Crossing a bifurcation is a concern because you covered some of the branch. But if you look at the balance of the flow, you have a lot of things that are possible. So this patient was treated in emergency. So in emergency, we put the patient under abscisimax, and we delivered the telescopic stent, which is a pipeline in this region, and we covered the basilar, we covered we crossed the aneurysm, and we covered the P1 on that side, and we went in the P1 on the other side. This is a perforator here. That's the reason why we choose this direction. So this is the immediate control angiogram. 1 day post-op, the patient presented with a mild left hemi anesthesia. And as you can see on the MRI, there is a tiny little stroke in the pons. And when we did another angiogram, we saw that despite the abscisimax, the patient is presenting a rapid thrombosis of the sac of the aneurysm involving the origin of the superior cerebellar territory. This is the angiogram at that time, which is 1 day post. So we stopped the abscisimax and we removed the Plavix to use the ticagrelor. We are not using Plavix anymore for the last 5 years. So ticagrelor was delivered to the patient. So this is the evolution of the patient post, immediately post-op. This is 1 day post, the one that you saw already. This is 10 days. Due to the treatment with the aneurysm, and we gave time for the flow diverter to divert the flow. And this is what's happening on a long-term basis. This is 5 months post-op. Aneurysm is gone. The arteries that have been covered are no more visible because there is another crossflow from the posterior circulation on the opposite side, and the aneurysm is cured and the patient is going well. So there is no question that this kind of aneurysm before the flow diverter, it was not really possible to do a real treatment, and a treatment which is going forever. This aneurysm we already saw, and let's have a look at this one. You know, I saw during this webinar a lot of giant aneurysm, and basically, you know, the giant aneurysm, when it extends in the distal territory, it's something which is difficult. First, there is a lot of mass effect, but most of the mass effect is due to the edema around the aneurysm, and some of the aneurysm keep on behaving like a real tumor. So this is the thrombosed portion, this is the patent portion, this is the patent portion that you can see, and this is what you have. This is third M3 aneurysm on a small branch, which is obviously the angular branch, and we definitely need to try to preserve this angular branch. This is a different projection to see the aneurysm. Today, it's not a deal. You can just navigate very easily with a tiny little catheter, which is a 17 micro catheter, the same catheter as the one we use for delivering coils. You navigate in the sac, you get out, then you extend, and then you can deliver the stent. A sick baby was delivered in this condition. So this is the immediately post-treatment. You can see there is still some flow going through the stent. This is a vaso-CT, which is a reconstruction of the CT done in the angiosuite. You can clearly see that the branch has been preserved and we are crossing the neck of the aneurysm. Now let's have a look at what's going on. The 6 months post-op angiogram is clearly demonstrating that there is no more aneurysm. In addition to that, the edema has completely diminished and regressed, and there is only a portion of the aneurysm which is thrombosed. So overall, after having your own philosophy of treatment, after looking at those cases where there is reasonable no choice to do except trying to do something from endovascular, the rest of the endovascular treatment is more or less, most of the aneurysm can be treated by the endovascular approach. I think this is a very important message for the future. How can you keep on, and we already discussed this, how can you keep on training neurosurgeons, understanding that with the evolution of the devices and the technology and the experience of the endovascular surgeon, we really don't need too much. Even the bypass surgery is going to diminish a lot because we have the possibility to reconstruct all the vessels that were potentially candidates for bypass surgery. So there is no question that it's a big point. Don't get blind, look at the future. It's not reasonable to keep on teaching neurosurgeons to treat aneurysm that they will not be able to treat in the future. This is a message. I know that you are going to react a lot, but if at my age, in my position, I don't say that, I think that I'm not helping neurosurgery. Thank you.
Thank you, Jack, for this wonderful presentation. And I just see Dr. Poggi, Giovanni has one comment or question. It's a wonderful presentation, and I agree with the statement you mentioned early in the webinar that train your people to the advancement, don't stick on something that you might not be using it 100% in the future. And as you said, the American way, now the young neurosurgeon, they will be trained for both. It's always difficult because a human being has always a dominant hemisphere that will dictate on him which he has to do. And there will be some bias, but at least for somebody who has the training, then he will understand when he see these like flow diverters, pipeline stenting, the value of it, and they start considering the approach over the others. Giovanni, you have comment or some question?
Well, I would like to make a comment about this last statement. Definitely, the future to have, first of all, compliments Jacques for all the presentation. In the future, definitely, we have to have a vascular neurological surgeon. That means that we'll be able to do interventional and surgery. Like, for instance, my friend Giuseppe Lanzino is doing in the United States. But at least in Italy, there is a law that is against that, because radiologists are against this project. That is the problem that we have in Italy. But that's we will work out. One question to you. Wonderful. You show that you can treat almost all aneurysm or giant aneurysm. My question is, when the giant aneurysm is clinically presenting itself as like a tumor, not like a rupture, you close the aneurysm, and that's wonderful. Who take out the tumor?
Okay. I'm not pretending that everything is a piece of cake. The giant aneurysm, it's a different song. A giant aneurysm might behave like a big tumor, even when it's completely excluded from the circulation just by the triggering of the angiogenetic factors. So this is a big concern. But let's have a look, frankly, about what's happening, most of the time. What's important in giant aneurysm is the edema, which is surrounding the aneurysm. And after exclusion of that, the edema, most of the time, just disappears. So even if you keep, an aneurysm which is shrinking, it's not disappearing, but it's shrinking. With time, the mass effect, most of the time, disappears. Now, suppose the mass effect doesn't disappear and you need to do something to remove, surgically speaking, the mass effect. When the aneurysm is excluded, it's just a piece of clot which is organized. So you can cut inside, you can do what you want, and forget about treating the aneurysm. You just remove a tumor or portion of a tumor. It's not going to grow again. You just remove portion of the tumor, portion of the thrombosis, and then you give space, and then you remove the mass effect. So I'm not saying that the mass effect is always disappearing. The mass effect is disappearing most of the time because of the edema, which is disappearing. If it doesn't, then remove it surgically. It's a tumor surgery. It's no more a vascular surgery because the aneurysm is already excluded from the circulation.
Any other comment?
I have a question.
Vladimir.
Yeah, Jacques, that's extraordinary what you are doing with this flow diverters. We love them also, and I believe that this is really the treatment of the vessel, that the vessel gets healed. However, there is a delay between the procedure and the final result. Several weeks, months, whatever. We have never seen a rupture during this period. Did you see a rupture during the period of healing?
Extremely rarely, probably less than 1%. Probably less than 1%. You know, the very important point, we were not believing that. Those blister-like aneurysm, it's a hell for everybody. Okay? Putting a flow diverter under antiplatelets treatment is the way to go. The complications that are related to bleeding after the delivery of the flow diverter is very, very rare. What's not that rare is in the meantime you need to get a complete exclusion of the aneurysm for waiting for re-endothelialization of the wall, the blister-like aneurysm might keep on growing. You know, we have cases where we were obliged to do 3 different treatments, putting flow diverter to get rid of this aneurysm. It was not bleeding, but it was keeping growing. You know, not everything is not solved, but it's evolving dramatically. And, you know, more and more in difficult situations, I think emergency is not a real concern. The concern is when you do the external shunt. You know, when the patient needs the shunt, you know, you better do it before, because then the patient is fully loaded with antiplatelets treatment. And this is another concern. I would definitely love to know exactly what we can do, surgically speaking, when you have a patient who is completely filled up with antiplatelets treatment after our treatment. There is a lot of potential complications. Some neurosurgeons are really afraid of that. Some of them are less afraid. Some of them are not afraid at all. I don't know. I need an answer to that. You know, I have been asking my friend Jua, what do you think? Most of the time he say, I don't care. If you do hemostasis properly, it's not a concern. A lot of neurosurgeons, they don't think the same. So this is a big concern. It's a big concern.
And let me provocate it a bit. Imar, I have heard your lectures some 20, 25 years ago for the first time. Already at that time, you were telling that there is no future for vascular neurosurgery, that there is no future for aneurysm surgery. How would you explain that we are still there now?
Oh, very simple, very simple. First of all, radiologists, neuroradiologists, myself, we were stupid enough, we are stupid enough, I was stupid enough, I am no more, to manage the patient without controlling the bed. If you don't control the bed, you don't have the power on the patients. And this is your strength. You control the bed. If you control the bed, you control more or less indication. You know, we are not going to do something in your bed that you don't want to be done. So this is a big, big concern. The second part, you didn't believe too much in the endovascular treatment originally, so it took time, definitely. Now you believe, now you get training, now you are taking over the business, and I don't care. Honestly, being a neurosurgeon or being a neurologist or being a gynecologist, if you get the proper training, if you do it properly, I am okay, you do it. The worst is to do something that you don't master. And the third point is, unfortunately, worldwide, we don't have access to the same devices. And this is a big concern because of regulation, because of money-wise, because of whatever. You know, I know a lot of countries in the world, they don't have access to all the devices that we have. Plus, in addition, if the patient cannot pay, he cannot get the treatment. You know, I am in a situation which is extremely favorable, you know, because I don't care about the cost of the treatment. I care about my salary, which is miserable, but the patient is fine. He doesn't pay anything. And I love this. Honestly, I love this. If they increase our salary a little bit more, it would be better. But nevertheless, this is the system. So, you know, there are many, many reasons why it's not growing that much. But honestly, most of the time, all around the world, it's not more than 20 to 25% of the aneurysm overall treated by neurosurgery. The rest is going through endovascular. Look at China. 10 years ago, they were not doing that much. Today, they're extremely good. They have developed a good technology. They have access to the devices, not exactly the same devices as the one we have, but it's growing dramatically. 1.4 billion people are now exposed with good doctors, with a good training for endovascular treatment. So it will go this way. I am 100% sure that less and less neurosurgical approach will be done. It's not a problem. It's the same discipline, and we are dealing with the same patient. So don't complain. We are not, don't complain, The best pasta in the world is in Italy. So, okay. So try to copy and don't complain.
Some 15 years ago, we managed to start a program or to put on paper the program of education for neurosurgeons to do endovascular, along with Pierre Lajanet. It somehow is still in effect within the European Union. But it's exactly the same what Giovanni is saying. We do not have the access to the X-ray machines. They don't let us. The same as you do not have the access to the beds, we do not have the access to the machines. And there was no help from your side over the years. We are the ones only pushing this education, this common education for endovascular, for neurosurgeons. But never ever any neurointerventional radiologist helped us to push this through.
So Vladimir, yes. There is a very simple answer. In 2015, we got those 5 studies, randomized study about the stroke. What's happening today? 5 years later, neurologists, they have never access to angio-suite 5 years ago. Today, a lot of neurologists are doing endovascular treatment and endovascular thrombectomy, and they have access to the angio-suite. No, everywhere. In United States, in South America, no, in France, it's not. In France, we have access to neuroradiologists. I know there is a lot of regulation, but forget about the regulation and think about the future. The regulation, they are here to be adjusted. So if we fight enough and if we are clever enough, we can manage a way to change the regulation. Europe, for the time being, can be one of the territory where it will be possible. I don't know, but think about what can be possible. If it's not possible for political reason, I don't know, then it's a shame for the patient.
I fully understand you. I understand that this is the future, no doubt about that. This is the same as vascular surgery. It's over. It's a past discipline.
Yeah.
But I don't know about Giovanni. Have you ever had a success? Do you have any neurosurgeon doing interventional in Italy?
Not in Italy.
Not in Italy.
In Italy, you have to have the board of neurosurgery and the board of radiology. That means a lot of time. Very few people are prone. Plus, the radiologists, I'm sorry to say that, are very conservative and they don't want to have somebody in their garden. That's the problem in Italy. I don't know what is around Europe or around the world. United States is a completely different situation. They can do both, but that's the United States.
Right.
But Giovanni,
yeah, go ahead.
I think it's not necessary to change a label on your jacket.
I think just wait a minute.
Yeah, the only thing you need is to be concerned about this problem. As far as you are concerned, you work all together in the same environment, the same bed, the same staff, the same everything. It's not because there is one single department that, you will be doing everything. Some will be doing endovascular and some will be doing open skull surgery. It will be exactly the same thing. But for the power of the discipline and the future of the discipline, we need unity. We definitely need unity.
Okay, I have IP Chevy.
In our settings, we have a neuroradiologist who is a part of the team and who is doing all the interventional work. And there is not a single patient in whom we perform any endovascular treatment who is not at the neurosurgical department. And it works well. This is one of the ways how to overcome this stupid, we call it nuclear law, what Giovanni was talking about. That was put on the paper, that we can handle provided there is 1 year of training in a respected place, you know, and then another one at home. We put it together with Pierre Lajanet, and it took a lot of time to put this together. But then you hit this nuclear law. In my country, neurosurgeon who would like to do endovascular, he would have to have a attest in radiology. It means that for a year or two, he will be describing lungs and broken legs. No one will do it.
I think, yeah, this is a problem all over except in the US and some areas now. But I'd like to commend Jacques about his objective ideas that unity is important, work in collaboration, and it's time for changes. The problem, as you said, they want the neurosurgeon to do radiology physics for 4 years, and he will lose the expertise on both sides before he starts anything else into endovascular. But let's hope the best, and I think we just want to not to put this arena, but this is an important discussion for the trainees because they want to see if they can attend or they are just go for 1 year or 2 years or 3 years, and then they should be like in the US system. We should adapt this system actually. Aipe Sherian, he has one comment, I don't know, from India, please, Aipe.
Hey, Imad, thank you very much. First of all, Jack Murray is a legend. There's no doubt. Excellent lecture. And best of luck with the dream that vascular surgery would disappear. I don't think that's going to happen for a long time, another 25 years more at least. I wish I could say that the cost doesn't matter, but it is not so. 5/6 of the world is low and middle income countries. And it is unnatural to have a treatment which is costing 100 times. And this is being pushed into all these low cost, countries where people cannot really afford. I'm seeing it in India. I have seen it in Nepal. And thanks to this, the skill of clipping, the skill of bypass is also disappearing. And again, as you said, clippers has also been stupid because aneurysm clips have never advanced. While the devices have advanced so much more, aneurysm clips have never advanced. So while I would say this would be part of the future, I wouldn't definitely say that this would be the future and vascular surgery would disappear. As long as countries like India, South America, Africa would exist, and as long as this economic system would not change, I don't think we can ever say that cost doesn't matter.
Yeah, nobody said that.
I'm sorry. No.
Yeah. Go ahead, Jack.
Cost is always a point where the discussion stops. Cost is a real concern. I agree with you. But there is no concern with any solution. There is always a solution. Second, if you look at the countries where it's supposed to be too costly to be used, look at the distribution of the devices. Why a same device is costing 3 times more in somewhere, I will not say the countries, compared to what we pay in France or what we pay in Germany. Because even in Germany, it's cheaper than in France. Why? Tell me why. Because along the chain of distribution, this is a 10% step. Each time there is a step, you take 10%. So at the end of the scale, it's 3 times more. So this is a cost problem too. So, be frank with everybody. As far as we speak about cost, we have to be frank with everybody and to speak honestly. The cost is a concern, but there is nothing that you should never forget that the cost depends on if you buy or if you sell. There is always a bargaining and there is always a possibility to find a solution, depending on if you buy or if you sell. Cost is a concern, but it's not a concern with no solution.
Okay, well, Jack, well, thank you very much for sharing your experience. Your thoughts is tremendously of value for the future of this practice. And we hope that things will change with the time. And I think we have to move for the next speaker. Wonderful.
I'm sorry.
I'm looking forward to have you one more time in our webinar whenever you have.
Thank you.
Thank you for sharing.
Thank you.
Bye-bye.
I think I'd like to invite the next speaker. I think, Vlad, you are the next online.
Yes, I know.
Okay, now show us the microsurgical technique for the
Do you have the
ophthalmic aneurysm.
screen there?
We're looking forward.
Well, this is difficult after Jacques, who has shown extraordinary images and extraordinary aneurysms. This is a training.
I support you.
So this is why I'm going to focus on one location only and on a simple surgery and to show how to do it. I hope that this will be interesting for the young people who probably got bored when we were discussing the costs of the devices. I fully agree with you, Jacques, in that because we have seen the same thing in shunts. Shunts were extremely expensive in Europe and extremely cheap in India. So this will be the same thing. All right, let's go to ophthalmic aneurysms. No conflict of interest, of course. How we decide between the clip and coil? It's fairly easy. The more blood in the subarachnoid space, the more we go for endo. Of course, the worse the WFNS score, the more we go for endo. The older the patients, again, more endo. And the more medium-sized aneurysm, because the huge aneurysms and really small, like blister ones, we still feel that surgery is better. And in ophthalmic aneurysm, there is another aspect, which is the more drilling is needed, the more we go for endovascular. And although the more the aneurysm is located below the optic nerve, the more we go for endo. So this is simple rules, which are, of course, not dogmatic, but which we somehow keep in mind and decide the individual. Over the past 10 years, we have had 150 ophthalmic aneurysms. Endovascular treatment was done in 106, so only in 42 we went for surgery. And this is the same ratio which we have in all the series of more than 2,000 aneurysms now, that 30% of the aneurysms are treated surgically and 70% by endovascular means. And we are happy with endovascular surgery by all means. So I don't really care whether the aneurysm is treated endovascularly or surgically, because what's important is the outcome. Should the patient be all right, then it's perfect by any means. Should the patient be in a bad condition, then any treatment is, of course, wrong. The only unfortunate thing about this is that in the decision-making process, you know that you've made your mistake only after. With the hindsight, you realize that you made a mistake. There is also a combination, this one an aneurysm which I clipped, and I was not really satisfied because I was unable to see the tips of the clip. So we went immediately to the OR, to the angio suite. This is 15 minutes after the last stitch, and we called the aneurysm. I'm not sure whether this was good thrombose or not, but this was rather elegant approach. Surgically, there is no inaccessible region in the brain. You may see nearly the whole circle of Willis from one single pterional craniotomy. This is like that. But for ophthalmic aneurysm, you really need just this small region where is the optic nerve and where is the carotid artery entering the intradural compartment. And this is the most rewarding surgery because it's like 10 minutes intradurally and you are done. This is a simple ophthalmic artery aneurysm just below the optic nerve, which is on the left-hand side, no retraction whatsoever, no dissection of the Sylvian fissure, no dissection of anything else except chiasmatic and carotid system. This is done like that, and this is the best advantage against the endovascular. As Juha says, you can kill the aneurysm, and you may be sure that the job is done. And if I overdo it, you may tell the patient, do not see him again. There are no recurrences after this. What were the techniques in these 42 cases? Proximal control, there was none in 37. I do not know whether it was my bravery or stupidity. In one case of large aneurysm, we dissected the carotid in the neck. In 4 cases, we have used the balloon. The last was the unfortunate case when the radiologist put the balloon by mistake on the opposite side carotid, and when the aneurysm ruptured, then really the was very, very significant. What about the drilling? There was none in 16 cases. It looked like the one I have shown you already. Sometimes only the coagulation of the dura just lateral to the optic nerve and medial to the carotid artery is sufficient to insert the clip. Targeted drilling in 15 cases, I will show what it looks like. And the whole anterior clinoid only in 6 cases and only in large aneurysms. I don't think that one really needs that at majority of cases. So surgical technique, this is simple craniotomy, but it really doesn't matter whether it goes supraorbital or frontolateral or pterional. In my mind, the large craniotomy or the regular size craniotomy gives you different angles of sight and much more maneuverability than the supraorbital approach. And this is what you need to see. This is the optic nerve, this is the carotid artery, and you do not need to dissect anything else. This is from below. This is the optic nerve here, the carotid artery. This is from our study on systems. And you really open only the optochiasmatic system and carotid system. Nothing else, no dissection is necessary. So let's go to a few cases. This is a happy lady with 2 aneurysms on carotid artery on both sides. This one was treated endovascularly and this one surgically. And again, this was very straightforward procedure, very similar to the first one. You see that there is space enough between the aneurysm and the optic nerve to insert the clip. Thus, everything you need is only to dissect the distal part of the neck, and then you may clip the aneurysm and then coagulate it. These are really probably the best surgeries, and they definitely are easier than the PCOM aneurysm because these are above the carotid. These aneurysm PCOM are mostly below, so you do not see the aneurysm that well as opposed to these ophthalmic aneurysms, which are really perfectly accessible and seen on all sides. Check of the blood flow, of course, is necessary. This is after. This is another one. Again, there is no drilling necessary in this case. And oops, yes. And the only dissection again is the optic nerve, the optochiasmatic system, the carotid system. Then you are directly on the aneurysm. And the only question is whether you will need to drill the clinoid or part of the clinoid or not. And in the majority of cases, you really do not need it. At least in half of the cases, you do not need it. And a good CTA prior to surgery should show you whether the aneurysm is covered by bone or not, and you can predict the need for drilling. And if there is a need for drilling, as I told you already, we really prefer endovascular treatment to surgical treatment. So this will be exactly the same as the first case. So let's skip that. This is after. It's like a carbon copy of the first case. This is the CTA, and you want to check the tuberculum cellae and anterior clinoid, which really tells you whether the drilling will be necessary or not. And again, even with drilling, you do not need too much space. You need to uncover the upper ring and then resect it. And Mustafa has said, falciform ligament. So you start your drilling medial to the optic nerve and you go only lateral to the carotid artery. You do not need to expose the lower ring and you do not need to cut the lower ring because there is the danger for the third nerve. The opposite is true for really paraclinoid aneurysm, as Mustafa has said. So this is the drilling, the red part. The most important is, of course, optical strut, because this allows you to get anterior to the carotid artery. And this is what you use when the aneurysm is large. So then you need, again, different angles of approach, and you need to see more, and you need to gain some space. The drilling is extradural because this is unlike in meningiomas, the aneurysm is always covered in dura. So unless you penetrate the dura, you cannot harm the aneurysm, and you use the dura as cover. So you start your drilling lateral to the carotid and you end it medial to the optic nerve. And here is the region of optical strut where the drilling must be more extensive. You do not need to drill the clinoid process which is here. So let's see one of those aneurysms with the drilling. It run. It does. So this is already partly resected. The clinoid process, the tip of the clinoid process is untouched. Here is the posterior part of the aneurysm. Here is the carotid artery. So what you need now is only to uncover partly the distal aspect of the neck, and then cutting the dural ring, separating the optic nerve from the carotid artery and the aneurysm. Here is the optic nerve, here is the aneurysm. I sometimes leave piece of the dura on the aneurysm because it doesn't matter, since you anyway need to go underneath and to uncover the neck where there will not be dura. And quite frequently in these aneurysms you need multiple clips, and you might try several types of clips and several angles of approach. What I really like is to reconstruct from above. So this is the first clip which occludes the aneurysm only partly. And here is the region of optical strut where the drilling is really needed to see the anterior bend of the carotid artery. And you see that there is a little remnant of the aneurysm anterior to this first clip. So there will be the second clip. Here is the mother artery, the carotid artery. You perfectly see the wall of the aneurysm starting from the carotid artery, so you can really put your clip very precisely. You can see it from the both sides because you are coming from above, and you can move the aneurysm. If you have a well uncovered optic nerve, you can move the optic nerve. You may not be afraid of this movement. So this is the second clip, which is anterior to the first clip. Then the third clip and fourth. So this aneurysm was treated by 4 clips, and that's rather frequent that you need to use more clips for the ophthalmic aneurysm. You see, this is the third that you can put it really directly on the neck in this region. And the fourth clip will be already angled from posterior, like that. And you see that the dural ring is left on the aneurysm. It's not necessary to dissect it, and it's just calling for the rupture. So this is it. Then you check it with ICG. Do we have it here? I guess yes. Okay, that's it. And you see the nice flow through the carotid artery, and you see that we are just at the origin of the PCOM. Nothing more is needed. And this is the post-op angio, which really shows the preservation of ophthalmic artery and the nice occlusion of the carotid neck. Another similar aneurysm, which looks really difficult. This is the optic nerve, and the optic nerve is split directly on the dome of the aneurysm. It will be better seen a little later, but it really, the optic nerve was nearly transparent, and the lady really, the patient came with visual disturbance, of course. That was the reason for surgery. And we wanted to decompress the optic nerve. And when I saw this, I saw that the patient will be blind after surgery. You will see soon what it looks like. So here we have the tractus. We have the carotid artery here. Here is the dura coming from medial to optic nerve, lateral to the carotid artery. Here is the tip of the clinoid process, which is definitely left behind. If you cut the dura and reflect it on the aneurysm, you may use this flap as some protection of the aneurysm during the drilling. And this is not time for drilling extradurally, it's easier intradurally. So you must remove all the cottonoids from the wound, because it will be 100% sure that you will get your cottonoid on the drill. And you see that there is no retraction, no spatulas, no dissection of the Sylvian fissure. It's just direct approach down to the optic nerve and the carotid artery. And again, this is drilled most anteriorly in the region of optical strut. And in this case, I really went quite far along the optic nerve, more than necessary because of the compression which was caused by the aneurysm. You may use the bone Cusa should you want. It's exactly the same. I just prefer the diamond drill, which somehow I feel is easier and safer because it doesn't push you to force everything. And this is the dural ring, which is cut, and you go laterally to the optic, to the ligament. You cut the dura. In this case, we took the dura out. This is the point where one should really be careful because there is the carotid artery is rather close. Of course, since it's dural ring, you see the carotid artery below the aneurysm here, and then you turn to the optic canal and you decompress the optic nerve and resect the whole piece of dura, exposing the aneurysm. The optic nerve is to the left, still split on the aneurysm. All the time checking for the neck of the aneurysm, at least for the distal part of the nerve. Now we are on the optic nerve, which is over here already. This is falciform ligament now being cut, and then going back to the dural ring of the carotid artery. And as soon as it's resected, the whole area gets very nicely exposed. You see the optic, you see the carotid, you see the ophthalmic artery, you see the aneurysm, you see the neck, the posterior part of the neck, the anterior aspect of the neck, and you see the bend of the carotid artery in its clinoid course. So this is a very, very nice approach and sufficient for any clipping. Now this is the last remnant of the dural ring. Sorry for my finger in the field, but I didn't already have the energy to edit the video more. And you see the optic nerve, how it's split on the aneurysm neck, but now it's nicely exposed. Here's space enough for the clip, which inserted after trying to dissect the optic nerve from the sac of the aneurysm, but it was virtually impossible because it's really completely flat. Sometimes one sees that in vestibular schwannomas with the sevens, and I really thought that the patient will be blind after surgery. Then we put the clip. Let's wait for that because there is another interesting aspect of the clipping. You see the posterior aspect of the neck. Here you see the bend of the carotid artery in its clinoid course. And here is the aneurysm, which is rather patient with us and doesn't rupture. And here will be the first clip, which seemed very sufficient and very nice, and which we control with the ICG. Again, you have lots of angles with this approach. If you come from perional, you do not fight with your clip applied, you do not fight with your suction. You really have enough space and enough vision and enough angles of vision of everything. That is why I prefer really regular perional craniotomy against the mini approach through the eyebrow. And you see now I again tried to dissect the optic nerve from the aneurysm. It again was practically impossible because you do not know where the optic nerve ends here, if this is only arachnoid or if this is already, if there is already some split neural tissue. So at this point we checked the flow in the aneurysm with the ICG, and it looked perfect. You will see it shortly. The ICG, that's it. You see that the aneurysm doesn't fill. You see the nice vasculature of the optic nerve, even as it is split on the aneurysm sac. So I wanted to decompress the sac, punctured it, and you see that despite the ICG, there is very nice bleeding from the aneurysm. So it means that one shouldn't depend on any technique. This may lead you wrong. So what was necessary was another clip. You see the jet of the blood from the aneurysm. So it means that this clip doesn't hold it sufficiently. So another clip, and that did the job. And after this, let's go forward. And this is the final image when I cut the aneurysm, decompressed the aneurysm, and the optic nerve somehow went back to its normal shape and normal position. And surprisingly, even with this manipulation, the vision returned to normal within the next 2 months. This is the post-op angio. These are another large aneurysms which may be clipped. And again, in this case, you need to see the aneurysm from different angles, from different approaches. You need to see the intraclinoid process. And then sometimes one clip is sufficient, but most frequently not. And most frequently the clip in these aneurysms slips either on the mother artery or out of the aneurysm. So it takes some time to get the best position of the clip, like in this other case. There are also other cases like this aneurysm, the dissecting one, which we didn't know what to do at all. So we trapped the aneurysm, and then you really need the bypass techniques. I don't know if Jack is still present and if he would comment on this aneurysm, whether he would be able to treat this endovascularly, but we treated by simple trapping and high flow bypass. The outcome in these patients was very good in almost all. These were all ophthalmic aneurysm. There was one bad outcome with hemiparesis, but the hemiparesis was due to ruptured PCOM aneurysm. Hunt has 3 and Fisher 3. Then one in vegetative state due to ruptured ACOM aneurysm. Hunt has 4 and Fisher 3. And one patient died. That was the most unfortunate. This gives altogether 7% morbidity mortality rate. And this is the patient who died. That was 73 years old lady with this partially thrombosed aneurysm. That's quite a long ago. And we went for coiling. We put the coils in. And most likely when the aneurysm thrombosed within the sac, it extended more pressure on the visual pathways, and immediately after surgery or few hours after surgery, the very fast and progressive visual deterioration appeared. So we went for emergency surgery, which was really difficult. We somehow managed, but it didn't help. And after surgery, the patient further deteriorated and died some 2 weeks after the procedure. So this was really unfortunate. So in conclusion, for ophthalmic aneurysm, there's easy access. It's really very straightforward and very easy. No retraction at all is needed. The proximal control, whether you achieve it by endovascular means or by exposing the carotid artery on the neck, or whether you would be doing those without, those which are not necessary for drilling, I don't think that it's necessary. You should have your adenosine at hand should you need it, and should you need a short cardiac arrest. Minimal drilling, don't drill the clinoid unless it's really necessary in large aneurysms. On the other hand, as in any aneurysm, you need the bypass techniques, and be prepared that you will use multiple clips. And don't forget that there is always endovascular option. Thank you very much.
Thank you, Vladimir, as usual. And we open the venue to take 1 or 2 comments, if any. Wonderful presentation.
Imad, one comment.
Yeah, go ahead.
Vlad, do you prefer to drill extradurally or intradurally in ruptured versus unruptured paraclinoid aneurysms?
It doesn't matter whether they are ruptured or unruptured. When the aneurysm is large, say more than 12 millimeters in diameter, something like that, then I drill extradurally, and then I drill whole clinoid process. If the aneurysm is unruptured, small, and I know is covered by bone, then I drill selectively and intradurally.
Okay.
Any other
Yeah, excellent.
questions? Any other comment?
May I?
Go ahead, Giovanni.
Compliments, Vladimir, for this presentation and for your skill in dealing with these aneurysms. They are not so simple often. Last slide, you say, remember always an end option. I will suggest to use always a possible option. Because I know, they tell you, because I personally have a patient with bilateral aneurysm, carotid ophthalmic aneurysm. One was done endovascular, became blind, and the patient said, do what you want, but I don't want this kind of surgery. So when the optic nerve is, as you showed, is deformated by the aneurysm, I don't think that endovascular is an option, because it will never shrink the aneurysm. Although Moray is not more present, but that is the problem for endovascular.
It's not true. I am here.
Giovanni, we now have a series of some 2,500 aneurysms since 2000, and since 2000 we have routine endovascular service 24/7. And in 3 surgical cases, I just let's say dissected the aneurysm, and I said I can do nothing. I really left as it was, closed the wound, and we went for endovascular treatment. In neither of these 3 cases, the endovascular guy was able to do anything as well. So it's perfectly, as you said, possible. Not the option, but possible option. Fully agree.
I want to see, I think Dr. Jacques Moray is still here. And the other things you see, I just want to ask Dr. Moray, when they do such a large or giant aneurysm, they are still having the concept flow director with overpacking. The problem was with these giants, the overpacking with coil, so they will never shrink. And many of the cases seen on video from colleague, they have to retrieve that coil piece by piece to decompress their optic nerve. Now, with the flow direct converter, do you think that the principle in the past to overpack this aneurysm to achieve complete thrombosis is still there, or you just do the flow diverter and with some kind of material that can be shrunk and disappear is only the thrombus can disappear, because putting coil fill that sac, it will never disappear, and the purpose of decompressing the optic nerve does not exist. So please, Jack, if you can answer this one and the comment from the colleague.
Yeah, I will try to answer. First of all, you have to understand that whatever you do, you cannot pack the sac of an aneurysm more than 30%. So, after you cannot keep on pushing coils. So the mass effect does exist, but it's not that dramatic. Second, if the aneurysm is excluded from the circulation, it shrinks. Even if it shrinks a little bit, it shrinks. And that's enough most of the time to decompress the structure around. In addition, the swelling and the edema is disappearing if the aneurysm is excluded from the circulation. So just by the conjunction of those two phenomena, a little bit of shrinkage and a complete disappearing of the swelling, usually the mass effect is not a concern.
I think this is the mistake on some of the interventional radiologists I know not from in your practice. They overpack, they don't consider the 30%. And this is one that comes the problem, they never shrunk. And then we start compressing the coil to relieve the optic nerve. I think Vladimir has some comment.
Yeah, Jacques, that was the last case I have shown, the patient who died. And we really didn't find any other explanation. Exactly, our radiologist kept this 30% rule perfectly. And still the deterioration of the vision was rather fast, and it was definitely caused by the procedure, because the patient prior to the procedure was stable for several months. So it must have been caused by the some let's say swelling of the cold aneurysm. So it's not 100% sure. And then
well, you know,
in the other case, what would you do?
No. There is a phenomenon. Yeah, there is a phenomenon that we don't master and don't control, which is the triggering of the proteolytic enzyme. Sometimes, for some reason, in a big mass, even if it's partially clotted, you put a little bit of coils to favor, or at least you think that you favor the thrombosis, and then you put the flow diverter. Aneurysm is gone, no feeling, nothing, and it keeps on growing, and it bleeds. So, you know, the proteolytic enzymes are triggered by the amount of clot. I think the most important is to transform the red clot in a white clot, which is much less prone to trigger the proteolytic enzyme. So one of the rationale to deliver coils is not to cure the aneurysm, is to transform the red clot in a white clot because of the fibrous tissue organization. Unfortunately, it's not 100% sure, and we don't know. You know, 20 years ago, I published a paper in which giant aneurysm were completely excluded. You have no view of the aneurysm on the angiogram, and the patient died. 2 or 3 of them died after 15 to 3 weeks, after 15 days to 3 weeks, just because of those proteolytic enzyme that we cannot master. Whatever you use, a high dose of steroid or whatever, it doesn't work. So we don't know. You know, some cases escape from us.
So you are telling that you are telling me that we shouldn't operate on this rapidly progressing vision deterioration?
No, this is not what I am saying. I am saying that it's better for you to operate. The problem, it's a bad condition. You know, you have something which is full of coils. The shell of the aneurysm is very active. When you do an angio-MR, not an angio-MR, an MR with specific sequences to show if there is some, you know, highlighting of the wall of the aneurysm. When you inject the dye, you can see that the wall is active. So you operate in a very hostile situation. So for you, it's not easy, but I definitely think that you better do surgery as soon as possible if you face something like that. Aneurysm keeps on growing, patient is deteriorating, go and remove as much as you can.
Okay, thank you, Jacques.
I think we are running a bit late. I'm going to invite the next speaker. Thanks to Vladimir for a wonderful presentation. The next speaker is Dr. Matthias from Argentina, and he's going to talk about a minimal invasive approach to aneurysm. Okay. Matthias, are you with us? Okay.
Yes, Imad.
Hi, wonderful.
Can you hear me?
Yes, and we see your slide.
Great. First of all, I want to congratulate you for your birthday. I hope you have a nice day, and congratulations to Imad and Vladimir for these 7 webinars. I know that the organization of these virtual encounters were really hard and difficult, and I want to congratulate to you.
Thank you.
Okay, thank you very much. This lecture is related to a special keyhole approach through the trans-abrow approach, performing a supraorbital transciliar for clipping aneurysms, especially for anterior circulation aneurysms. Okay, we will analyze the microsurgical anatomy for the trans-abrow approach, and I want to thank to Maximiliano Núñez, an Argentinian colleague who helped me with some beautiful dissection of this minimal invasive transcranial surgery. First of all, I want to say again that it's very important, the anatomy, the laboratory training. Some of the dissection that I will show you were made here in Argentina, in Sao Paulo, in United States. And before to operate my first patient through trans-abro approach, I was working several months in cadaveric specimens. And this is very important, especially for young neurosurgeons, the laboratory training before to operate patients, especially with new techniques. The preoperative studies are really important, and the preoperative planification when we plan to perform a keyhole surgery is very important. And the surgical technology, of course, because the microsurgical instruments are especially designed for this kind of procedures. It's very important to be familiar with the classical approaches, for example, the bilateral craniotomy, the supraorbital frontal craniotomy, transglabellar, the pterional, the orbitozygomatic craniotomy, and it's important to be familiar too with these minimal invasive craniotomies as supraorbital transciliar approach. And with this kind of surgery, the surgery is possible, of course. We can offer a faster surgery and excellent cosmetic results to our patients. When there are many, Dr. Pernesky was a pioneer in this kind of keyhole surgeries. It's very important the positioning of the patient, because we need to use the deflection of the head in order to create a straight corridor between the inferior surface of the frontal lobe and the anterior cranial base. Okay, we use the abro to perform our incision. Generally, we perform a 3 centimeters of skin incision. After to perform the skin incision, we need to dissect the subcutaneous tissue, and our medial limit of our dissection is the supraorbital nerve. It's very important to demarcate the supraorbital canal or foramen in order to avoid the damage of this important nerve. We need to expose the frontozygomatic suture in order to localize the keyhole foramen. Okay. Another important nerve that we have in this kind of minimal invasive craniotomies is the frontalis ramus of the facial nerve. And we have these small branches of the facial nerve in the region of the supraorbital transciliar approach. Some vessels we will find here. Here is the medial border of our skin incision. The orbital muscle is retracted inferiorly. We can use only in the superior skin, not in the inferior skin, in order to avoid the damage of this muscle and, of course, the age. As you can observe here in this dissection performed in the United States, here we have the supraorbital nerve, and laterally, this is the medial border, and laterally we have many small branches of the facial nerve. And this is an important thing to keep in mind when we need to perform these keyhole surgeries, because our incision, after to perform the skin incision, should be laterally to the superior, to the supraorbital nerve, and in a curved fashion in order to preserve these branches to arrive the frontalis muscle in this region. Here, a right dissection preserving the abro we have here all the ramification of the supraorbital nerve and some kind of connections with the frontalis ramus of the facial nerve. After to perform the incision, we need to expose the temporalis region in order to perform the keyhole foramen. Yes, here behind of the frontozygomatic suture, we need to expose this region in order to perform the foramen. We can use it, we can perform it with 5 millimeters tip of the drill. When we perform this foramen and the craniotomy, it's very important to remove the mammillary eminences of the roof of the orbit in order to create a straight angle of visions between the inferior frontal lobe and the roof of the orbit. It's very important to perform it. The dura mater is incised in a curved fashion with this base inferiorly. And we can see some structures. We can see here the optic nerve, the left optic nerve, the right optic nerve, the chiasm, the carotid artery, the anterior cerebral artery, and the middle cerebral artery, and of course the bifurcation of the carotid artery. Here in a higher visual field, we can observe the carotid artery, the anterior and middle cerebral arteries. And we can approach some special kind of aneurysms using the trans-Avor approach, especially for dorsal ophthalmic aneurysms, for posterior communicating aneurysms located or facing the lateral border of the carotid artery, and M1 or ER1 or carotid bifurcation aneurysms. These locations are special for planning this kind of keyhole surgery. Here, it is not a good angiography, but we can observe here the posterior communicating aneurysms facing laterally in the right carotid artery. We try to do angio-CT in the preoperative period and reconstruct the window of the bone that we need to use through this keyhole surgery. And we can observe here the aneurysms in the preoperative study. The surgery starts with a skin incision in the center of the eyebrow. We do this surgery with microscope from the minute 1 to the last minute in order to work with the detailed technique. We use, as I told you some minutes before, some hooks, especially for the superior border of our skin incision, and for the inferior border, we prefer to use some anchoring points in order to retract properly the skin. After to reach the bone, we need to localize this small segment of bone located behind of the superior temporalis line, and only we need to expose the anterior cranial fossa. Yes, the first burr hole, the only burr hole that we use, is located superiorly to the keyhole of the pterional craniotomy. After to perform this initial burr hole, we complete our craniotomy with a drill, and our craniotomy is really small. We have 1.5 centimeters to 2.5 centimeters in the transverse diameter. After to expose it, it's very important, especially for young neurosurgeons, to remove the bone in the inner layer of our craniotomy in order to in order to improve our microsurgical visions after the dural opening. Another point that is very important is to remove this bone located in the inner table in the inferior border, and it's very important to remove the mammillary eminences located in the roof of the orbit. We can observe here some periorbital fat. It is not a problem, not at all. And the dura mater is exposed. We open the dura mater, and we can observe the pole of the frontal lobe in this point. We use the subfrontal corridor using the olfactory nerve as a landmark. This is the olfactory nerve that is a very useful anatomic landmark for reach the optic nerve, and of course, in order to localize the carotid artery. We can observe here the anterior cleanout process, the right orbit, the right optic nerve. This is the carotid artery. We can dissect the carotid cistern, the optic cistern. There is the pituitary stalk behind to this small piece of cotton, and the hypophysis there too. The chiasmatic cistern, the tuberculum cellae. And of course, with this approach, we can expose the sphenoidal segment of the sylvian fissure, and we can open it if it is necessary to clip the aneurysms in some special cases, of course. Here is the aneurysm exposed. We can dissect the distal neck, the proximal neck of the posterior communicating aneurysm. There is located the third cranial nerve under the carotid artery, and with an angle clip, we clip this small and elongated posterior communicating aneurysm in this case. Here is the aneurysm clipped, and of course the closure in a regular way, as we can observe. Here is the postoperative angio-CT with the aneurysm correct occluded. I will show you the second case in order to sample a posterior communicating aneurysm with the fetal posterior communicating artery. I will advance the video, of course. We perform the craniotomy in the regular way, exactly the same as like the first video. And when we start the surgery, we need to work with all angle microsurgical instruments. We can observe here the anterior cleanout process, the right optic nerve. In this case, it was necessary to open the sylvian fissure in order to expose the whole aneurysm sac. The sphenoid segment of the sylvian fissure is very easy to access and to dissect using the supraorbital approach, not the lateral surface, because it's far from this approach and it is not exposed, of course. We can observe here the carotid artery with the white color. The patient have some cardiac problems before to the surgery, and we can expose the proximal neck, the distal neck of this big aneurysm, and we clip it with a straight 9 millimeters definite permanent clip to this aneurysm. The aneurysm was located inside of the uncus of the temporal lobe here, and we need to dissect the aneurysm in order to avoid the mass effect that the patient suffered in this region. Finally, we can observe here the dome of the aneurysm dissected of the uncus the parahippocampal gyrus. Once we clip it, we check the correct patency of the posterior communicating aneurysm. We puncture the dome of the aneurysm. We check that the aneurysm was perfectly occluded, and with the microcisor, we opened the whole aneurysm in order to avoid the mass effect that her temporal lobe suffered with this aneurysm. And here we can observe the internal surface of this aneurysm in this case. Here, the internal surface of the aneurysm perfectly occluded. This is the angio-CT in the immediately postoperative surgery with the posterior communicating artery with correct patency. The patient, the postoperative period, of course, the cosmetic results were good. The frontalis muscle was perfect too. And the last case I want to show you is this carotid bifurcation aneurysm. We planned the surgery with the angio-CT. It's very important for us in order to reproduce a real scenario like we will have in the surgery. This is a short video where we can observe the incision through the eyebrow. The dura mater exposes is really small. We can observe here the opening of the dura mater of the frontal pole in the same fashion with the base in the orbital rim. The inferior surface of the frontal lobe, the left optic nerve is exposed here, of course, and we need to dissect the sphenoid segment of the sylvian fissure in order to expose properly the carotid bifurcation in this case. This is the carotid artery, the third cranial nerve, the middle cerebral artery, and the anterior cerebral artery, and with the right 9 millimeters permanent clip, we occluded this carotid bifurcation aneurysm. Here we have the preoperative angio-CT and the postoperative angio-CT. Some interesting comments about this kind of keyhole surgery. The surgery was, the duration of the surgery was 19 minutes. Only one clip cost $100 and 2 days in the postoperative period. And after that, all the patients received the hospital discharge. Finally, I want to share with you this interesting paper that we published some months ago in Interdisciplinary Neurosurgery about supraorbital transciliar approach for posterior communicating aneurysms in a 3D surgical video. Thank you very much, Imad, Vladimir, for your kind invitation.
Thank you very much, Matthias, being on time. We'll give a chance for one comment or question. Toward the end of the day, people, they get depleted from questions because they are ready for either to sleep or for dinner.
Can I just mention?
Yeah, Ramesh.
Thanks, Matthias. That was a great talk, and the slides were superb, including the videos. What is your technique to deal with a very well pneumatized frontal air sinus? How do you seal it off?
Thanks, Ramesh. If we have a very pneumatized sinus, when we perform the craniotomy, we need to treat the sinus as a regular way we use with the pterional or frontopterional craniotomy. Yes. Sometimes we need to open the frontal sinus and we remove the mucosa and we treat it with muscle or with bone wax.
Okay, thanks.
I think it's an important point when you go, as you mentioned, lateral to the supraorbital nerve. the chance to enter the sinus is remote unless you have an opera singer that he has a big sinuses. But being lateral to that nerve, the chances will be less. We have published about 20 years ago 16 cases using this technique, but we added, we use it for even for supracellular tumor, but we added taking the rim of the orbit as we are doing a mini fronto-orbitozygomatic, and we put it back. But thanks for Dr. Pernensky, who has introduced this subject. And it depends. Some people, they don't like to have a scar in the eyebrow, but you showed fantastic cosmetic results. In my series, they were not always nice cosmosis. And if they are bald, this is the preferred incision for them. But if they have hair, I'm talking about supracellular tumors, they don't mind to have the hairline incision. Thank you very much. Any other comment or questions?
Thank you, Imad.
All right, so I wish we might not see each other on Zoom until next year. I wish everybody a Merry Christmas and Happy New Year, and a great time with your family. And we are looking forward to have the vaccine introduced so we can see each other and visit each other and have a real live presentation with having a nice dinner together. I'd like to ask all the members to give their comment before we conclude the final webinar for this year. Please, we'll start with Vladimir.
Well, it was great. All 7 seminars were great. And I believe that I'm not the only one who wants to thank you. And I would like to say that this is my thanks to you, to your birthday, for everything, because you gave us a gift. We should have given you a gift to your birthday, but we cannot. But
no, being with me, this is the best gift.
And best to Huda also.
Thank you, man.
It was excellent. These 2 days were really, really extraordinary speakers, and all the lectures were perfect. So I enjoyed myself very much. Thank you, Imad.
Thank you. Giovanni?
Well, I think that we, all of us are very happy with the success of the 7th webinar, but the merit of the program and the constant attitude to promote that is to Vladimir and to you. And I think that is very important to recognize your driving force for that. And of course, compliments for all the speakers that we had. Happy Christmas, Happy New Year, Happy Christmas, Happy New Year, and happy birthday for you today.
Thank you. Victor?
Hello, everybody. It's really nice to see you all. These webinars were really fantastic, amazing lectures. I think that the mission of this Committee of Neurosurgical Anatomy of World Federation of Neurosurgical Societies, the main mission is neuroanatomy applied to brain surgery. So I am very happy and feel very honored to be involved with this committee. Thank you so much, Dr. Imad Khan, Dr. Vladimir, and everybody. As a Mexican, it's a really honor to be with all of you.
Thanks to have Ramesh.
Thanks, Imad, and happy birthday to you, first of all. And thanks, everyone, to be this into this wonderful endeavor. Even though this pandemic was a curse to all of us because we miss seeing each other for some time now. Even though we had a full program this year without the pandemic, it's all went down the bin. But in a way, it's a boon as well, because I was listening to all the comments from the audience, and many who would prefer webinars because it's such a useful thing, as they cannot travel everywhere to listen to these talks from all these masters. So it's, in a way, it's an opportunity for us as well, and we've taken really advantage of this pandemic in a very useful manner. Thanks very much.
Thank you. Matthias?
Thank you very much,
Yeah,
Imad and Vladimir, for this opportunity. It's a big honor. I feel very proud to be here with you, with Pablo, with all the members of this. More than a committee, it's a family. At least for me, I feel like that. And well, I wish you everybody have a happy Christmas and happy New Year. And really, I am waiting to see you all in person.
Thank you. Salman, I'm seeing Salman with us.
Thank you, Imad. I think, as always, Imad and Vlad, you have really done justice to be the leaders in this committee. I think what you guys have achieved over last this year, it's amazing. And the number of people who have learned so much, and people who write to me and say why we should continue with webinars. Many of them can't travel to these places, or many of them can't afford it, or many of them, don't have the resources to get there. And to have lessons from the top people in the world, and you accumulated them every time, the best people in the world giving talks and spreading the knowledge without any cost. So they don't have to travel; they're sitting in their houses. It could be in Africa, in South America, wherever. So I think you guys have just done a brilliant job. And I thank everybody who's taken part in this. And you've got huge loads of people supporting you, and I thank them all. I can see majority over here, so it's wonderful to be a part of this committee. I'm grateful to everybody who's done great work here. Thank you.
Thank you. I'm seeing Ramesh Carollo.
Yes, thank you, Imad. Thank you for allowing me to be part of such great friends and with common philosophy of conveying the anatomy to practical knowledge and convey it to all the people who will benefit from it. It's a great honor to be part of this philosophy, and happy birthday, and hopefully a better new year next year.
Thank you. I left the best for the last two guys. I'd like to thank myself, Pablo Gonzalez. He was the dynamo of this webinar. He has organized a lot of logistics for us, initiating the webinar, arranging the contact. Fantastic. I know he was busy today, and I'd like to thank him, and I'd like to give the venue for him to have some. And best to Adriana and your parents.
Thank you. Happy 38th birthday, Imad. I'm so happy.
I think 30 years ago.
I can just say thank you. I'm sorry I missed part of the webinar today, but I could see Vladimir. I was hearing you while I was in the car, and I just can say that this family was an amazing family 1 year ago, a very small family, and the pandemic and your effort, Imad and Vladimir, has made this family quite big. I mean, I think we are 1,000 people now in this family, which is just fantastic. So I just can congratulate you, and please keep going. I told you many times we cannot stop this because it's helping all of us. And congratulations to both of you and to all the family members and the faculty that they are taking their time. I know these 4 hours webinars, where families are complaining sometimes of how much time we are investing on this, but it's worthy, I believe. So thank you.
Yeah, thank you. Special thanks to Takashi, Professor Takashi Kun from Japan. He is the man behind the curtains. He has translated all the webinars to our colleague in Japan. And I'm sure next year we'd like to see you on the faculty giving a presentation of your choice.
Okay, thank you, Vitan. Thank you, Dr. Imad and Dr. Vladimir, also Dr. Pablo, to every committees in the world. It's a great opportunity for me to participate in this WMS community meeting. So, and contribute to Japanese residents and Japanese doctors to English to Japanese translation. This time, Dr. Kato and Dr. Oya, great Japanese neurosurgeons, gave a lecture, and we learned a lot. So we learn together, and learn more for further neurosurgical learning. So from next time, so I study hard to join again, participating again in that meeting. Thank you, everybody. They have a good Christmas. Have a nice New Year.
Thank you. I want to ask Pablo, am I missing anybody? I don't see.
Ipe is there. Ipe is also there.
Ipe is there.
Ipe. Yeah, I didn't see his picture. Well, we give the venue to Ipe now.
And Ek also joined.
Okay. Yeah,
so you have to unmute.
Sorry, I'm on call. That's why I'm having a crazy day. But
yeah.
I recovered from my little blurb yesterday. Yesterday I was in the middle of a skull-based meningioma giving my talk.
Hey, Imad, and
I'm sorry, that was crazy.
Okay, if you want to give some final statement for the conclusive webinar for this year.
I would like you all just know how a fantastic job you're doing. The feedback that I get from my residents as well as colleagues is the most detailed one that I get. It's not random people I meet on the street, right? And they are all really thrilled about the quality of the presentation and the good educational outline. I think a lot of our presentations have really hit the nail, and that's how I see our mission. I think it's beautiful to have this group of highly skilled teachers available at hand. This is one of the things I bring home from the COVID period, that we can get much better education done through the Zoom platform. And I'm super proud to be part of this. And I'm really happy that Imad and Vladimir have pulled this off in a most phenomenal fashion. So just my 5 cents. It was a pleasure to be on board.
Thank you. Ipe is in the middle of the night, perhaps. Ipe?
Well, before we start, let me say one thing which I have learned, which is interesting. I have checked the YouTube channel for our seminars. Majority of other seminars, the hits are in low hundreds, 115, 200. All ours, which I have found, the hits are in thousands, which means that you, Imad, are doing perfect job.
Thank you. Thanks. Ipe, I think he's delayed with his voice. So
I'll take the opportunity to speak in before I can.
Yeah, Modi is there.
Modi, yeah, go ahead.
My video is not on for some reason. It's not coming on. Maybe the world doesn't like to see my face. That's fine. But Imad, it was bringing back memories of the beautiful birthday party we had at the sea on the White Sands.
Yeah,
So it was a great event, and all the faces, most of the faces on the screen were there. So it really brought back wonderful memories. So happy birthday to you, and
thank you. We were together. That's correct. Yeah. Thank you.
In Mombasa at that time. Yes, we enjoyed that. So
if you want to say something for the committee and the webinar, yeah,
yes.
Go ahead.
I'd speak for myself, but also for the Continental Association of African Neurosurgical Societies, because the African residents really are always yearning for education. And those who have logged onto this webinar have really been very complimentary of everything. And of course, Pablo comes to Zanzibar to give them hands-on lectures regularly. So really, all the team that is here, Ramesh, Salman, Vlad, Pablo, Ipe, who have been to Africa on behalf of the African Neurosurgical Societies of the continent, I'd like to say thank you very much. Keep it up, and we're really pleased that we could pull this off brilliantly. Thank you again.
Thank you, Modi.
Guys, I would like
Ipe.
Can you hear me?
Yes.
Right. So, Imad, happy birthday. Many, many happy returns.
My brother. Thank you, my dear.
And one thing that I must say is that, 4 years to 5 years back, John Bennett came to Nepal. And I remember starting neurosurgical TV 4 years back. And we didn't know what the prospect of webinars or Zoom was at that time. I remember starting it at that time, and we started giving webinars. Now, the WFNS Neuroanatomy Committee, I am so happy that you guys are involved in this, and I can see the quality of webinars and how much it is helping. I would like to appreciate the guy who is silent and who is a workaholic behind all these webinars, John. I would like to give enough credit to Vlad and Imad, who's been organizing this, Pablo, who's been doing a great job with all the supports and everything, and all the other teachers who has been giving their time to help. You know, this is not easy, sitting 2 days, leaving your work and sitting for 2 days for a long time in front of webinars is not easy, but I see that all of you, I mean, my family, all of you have been extremely good at it and extremely been helpful in spreading knowledge all over the world. No wonder it's one of the best webinars ever done. So credit to you, Imad, Vlad, and Pablo. Thanks a lot.
Thank you. Well, I'd like to send the regards for all the international speakers that they were with us today and the other webinars. I think some of them left already. And to the members they are absent today, I wish them all the best, and for their family, I hope we'll see their activities in the upcoming webinars. Without further ado, I think you are all tired, and I wish you all the best and your family. My best regards.
Thank you.
Take care. Bye-bye.
Thank you.
See you
Thank
next
you.
year. Thank you.
Bye-bye.
Have a good night.
Bye.
I wish you a good Christmas and Happy New Year.
Yeah.
Happy New Year.
Yeah.
For everybody, take care.
Bye-bye.
Okay, Happy New Year.
Bye-bye.
Happy New Year.
Bye-bye.
Okay. Bye-bye.
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 Bye. See you next year. Bye.
Ayıp biz gone.
Hey. You guys. Wait. Have a good night.
Bye-bye.
Good night. Thank you. Thank you.
Bye, Ramesh.
Ramesh, thank you.
Bye, Victor.
Very, very happy to see you, Ramesh.
Have a happy Christmas and a New Year.
Hope to see you next year here in Mexico, in Acapulco.
Yes.
Bye-bye.
Bye-bye. Bye, Ramesh as well.
Bye, Ramesh.
We finished. John, thank you.
Okay.
Okay.
So everything work okay?
Yeah.
Hold on.
Okay.
Yeah, can you explain how basically what you're doing? We start the Zoom with me. You're broadcasting, but how are they getting the broadcast? How is your audience, the Japanese audience, getting your
Japanese audience using your neurosurgical TV or some other webinars and attend and join in the webinars and then listen. So I'm using another iPhone and
to translate, like you're turning off the sound and translating from your phone?
Yes, from my phone and translating and talking in Japanese, and to some of my friends, the SNS, via SNS, or Facebook, or some telephone. But some of Dr. Yasue Tanaka attended doing this neurosurgical TV. And some of my friends, from your site, neurosurgical TV or YouTube, and join.
Yeah, because we could do it with Chinese, we could do it with Russian,
Russian?
people like people like you. They get on the panel with the same thing. You know what I mean?
Yeah.
You could have another. You could have the major languages. No, really, you could get a Russian neurosurgeon, a Chinese neurosurgeon, and they could do the same.
Okay. So, so next time, we continue to join, and so some faculties and members appreciate Dr. John Bennett to Nepal or India.
Yeah, well, if you have Japanese or any conference you want to translate, just tell me. We'll do it.
Okay, so Japanese meeting, so I can translate Japanese into English. It's available.
Okay.
So okay, so I will discuss some other colleagues and
yeah, think about it. Think about it.
Oh,
think about it.
so
But we're open for ideas. We're open.
Okay, so
because just like you're doing, we have to push technology. We have to push it to see
push
what it can
technology.
do. What can it do? We can't be afraid of it. We have to. We can't be afraid to fail, because that's how you learn. You make mistakes. Say, okay, let's try something else. Let's try something else.
Yeah. Okay.
We're pushing, but this is good.
Good. Okay. So,
So
it's a great opportunity. So great
just
opportunity.
keep in touch. Keep in touch.
Yeah. Keep in touch. Thank you. Thanks a lot. So we'll continue. Yeah. Okay.
Bye-bye.
Someday. Good night. So for a long time. Thank you very much.